Okay. Good morning, everyone. Are we? Oh, no, of course we're not. Hold on one second. Let me get the camera up. Every time I turn that camera off, it loses connection. Oh, that's why. Okay. I missed a step. All right. Ah, there we are. Okay. Oh, we're going to start questions early. All right. Good morning. Can a person with a disability due to rheumatoid arthritis study and become a CNA? This person is able to do hard work because she has the disease under control. Thank you and blessings. Yes, Maritza, absolutely. As long as you're physically able to do the work, then no disability should stop you. So it really, it depends on, when you're talking about, good morning. You're talking about disabilities stopping you from working in any capacity in healthcare. It's based on your level of ability, not your disability title. Does that make sense? Okay. So yeah, there are people with hearing impairments that are CNAs, even though we have to take blood pressure. There's people that need mobility aids to get around. So it just depends on your ability to actually do the job. So I hope that helps. Okay. Let me go ahead and get your scores. You had chapter 6, 7. Thank you. 7. I just want to get that up there. Okay. So you had chapter 7. Let me go ahead and get your scores. Isabella? Okay. Isabella, do you have 4, 5, and 6 for me as well? 90s. Okay. Very good. Kiana? Julia? Jay? 90. Thank you. Erica? Sophia? Victoria? 100. Thank you. Christine? Cleonta? 100. Thank you. Autumn? 100. Thank you. Chloe? Adriana? Thomas? 95. And then for chapters 5 and 6, both 100. Thank you. Lisette? Janae? 80. Thank you. Jamar? 100. Thank you. And Salif? Okay. All right. Any questions on what we've gone over so far? Any questions? Okay, a very, very quick review. Very quick. So how do we know what to do with each patient? We follow the care plan, the whole care plan, and what are we supposed to be doing while we're doing the tasks on the care plan? And who do we report that to? The nurse. Remember that those are the 2 parts of the CNA job. Following the care plan and making and reporting observations. They are equally as important. A lot of students, when they get to the test, they just focus on the skills, the doing, the following the care plan part. But the written test is going to be judging you on the other part of it, the making observations and reporting them. So if you have not gotten the ebook yet, if you've not downloaded that ebook that we have for the written test, now is a good time to do that. because it's going to help you put those two pieces together. Because in this class, we're focusing on skills. And that's why I do this, because although we're focusing on skills, remember, half of our job is observation and reporting. If we don't know normal, how are we going to determine abnormal? That's what's going to set the CNA apart from everybody else in healthcare. Good. So I was actually on the phone with the dean of the largest nursing school in the country yesterday, and he was asking some questions about, they're developing a program, a new pathway for their nurses to get their CNA before they go into nursing too. And he was asking for some input on how to structure that effectively, because they have such compressed time. Good morning. So we were having a conversation, and he actually asked, he says, so what is the difference between CNA and home health aide or PCT or nurse tech or all those other terms that you're going to see out there? And so I explained to him that the biggest difference is CNAs are certified, which means they pass the test. If you haven't passed the test, we can't call you a CNA because you're not certified. We used to just call you a nursing assistant, and that was easy. It was just nursing assistant or certified nursing assistant. But then employers got involved. And employers decided, yeah, we want something different. We want a different term. So they all made up their own. PCA, PCT, nurse tech, attendant. I mean, you'll see all kinds of terms. Those are all made up by the employers. There's no standardization. There is no regulation. They're just different names for non-certified assistants. Make sense? So what's the difference between a non-certified assistant and a certified one? Observation and reporting. Good? Does that make sense? Do you see why this is so important? This is really what defines you as a CNA. Okay? Good? All right, let's talk about the opening. I gotta stand up here. Let's talk about the opening. So with the opening, every skill starts with the opening. What does every opening start with? A knock. Okay. So some of you guys were practicing yesterday or on Monday, and we were kind of struggling with this whole opening thing, remembering all the steps of the opening. So this is one of those things that you have to go home and practice. Just so you can say it, it can roll right off your tongue. You don't have to think. I don't have to think about, hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? Close curtain, wash hands, get supplies. I don't have to think about it. It's all just right there. I mean, right now, my brain is somewhere else. It's my granddaughter's birthday. So happy birthday to her. I don't have to think about it. It just rolls right off my tongue. Well, for the test, you are going to be stressed like there's no tomorrow. And you have to have a starting point. That's the hardest part of doing any skill, is starting it. So if you take the time to memorize this and say it over and over, when you're driving your car, knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA. Oh, use your name, not mine. I'm your CNA today. I'm here to whatever. Is that okay? Close curtain, wash hands, get supplies. So as you're driving down the road, you should be saying that over and over. Make a little note card, put it on your dashboard. When you're cooking dinner, have a little note card, put on your kitchen cabinet so you can read it as you need to learn this so it becomes part of you. If you do that, the test becomes super easy, because this is the hardest part, getting started. Does that make sense? So that's the biggest testing tip I can give you, is learn the opening so that it becomes part of you, so that the rest of the skill is easy. Because what ends up happening is when you go into test and you're stressed, you'll forget to do the opening completely. You'll just go over, grab your supplies, and start working on the patient. And now you're touching the patient before you washed your hands. And that is an automatic fail. So this needs to be part of your testing strategy, learning this. So knock, knock, knock. Hi, Mrs. Jones. My name is Patty. I'm your CNA today. I am here to whatever. Is that okay? I'm going to close the curtain, wash my hands, get my supplies. So our steps are knock, greet our resident, address them by name, introduce yourself, describe the skill that we're going to be performing, obtain consent, close your curtain, wash your hands and gather your supplies, and don't touch the patient until your hands are clean. All right, so sometimes we have to use gloves for some skills, not all. Should we wear gloves for everything, every time? No, because you stop paying attention to what you touch with those gloves if you do that. So now if we're not going to wear gloves for every skill, every patient, every time, now we got to figure out, okay, when do we need to wear gloves? So we have 3 rules for that. If we're going to touch body fluids, personal skin, or non-intact skin. If the answer to any of that is yes, you need gloves. If the answer to any of that is maybe, you need gloves. If the answer is I'm not sure, you need gloves because there's a potential there. Okay. If you're just going to touch intact skin, if I'm taking your pulse and you have no body openings, I don't need gloves for that. But if we do decide to wear gloves, what's the first thing they should touch? Not the supplies, not the bed controller, not anything else, the patient. We have to keep those gloves clean for the patient. And then once we've done the skill, we have to be careful about what we're touching in the environment to prevent cross-contamination. And then we're going to remove those soiled gloves correctly. So to remove soiled gloves, we pinch up, pull off, and then go under and pull off. All right, barrier, used anytime we use supplies. So if your skill has supplies, it automatically comes with a barrier. We should get the barrier first before we get the supplies. That way we're not holding our supplies against our uniform. Yep. What kind of hands do we need to get those supplies? Clean. So that means this has to be done after our opening and hand washing. Don't start your skill by getting your supplies. The skill starts with the opening, not the supplies. Good? All right. And then sometimes we need to use a privacy blanket. How do we know when we're supposed to use this thing? Uncovered or undressed. If the skill has the patient uncovered or undressed, we need a privacy blanket. And they're used not just for privacy. Why else do we need that blanket? Keep them warm, because when we take that sheet off, they're going to feel very cold. So when we're going to take when we're going to use the blanket and take the sheet away, right? So the blanket's covering the patient. How do we do that? Do we just take the sheet off and then put the blanket on? No. How do we do this? Blanket over the sheet and the sheet pulled down underneath. All right. And when we're putting that blanket on, what do we have to be careful not to do with it? Snap it or shake it. All right. And at the end of the skill, when we're ready to take that blanket away, should we take it away with soiled gloves? Okay, good. Linen rules. These are mostly repeats of stuff we've already gone over. So what kind of hands do we need to get our linens? Clean. What can't our linens touch? Uniform. What can't we do with linens? Shake them or snap them. Those are all the same. Clean rolls toward me, dirty rolls away. And we don't want anything to touch the floor, not clean or dirty. So be careful when you're making that bed, as you're securing the corners on the edge of the bed. Make sure that sheet doesn't slip onto the floor. And if it does, don't ignore it. So for the test, if that sheet kind of goes down and hits the floor, don't think that evaluator didn't see it. I guarantee you they did. And they're waiting to see what you're going to do. Because in a clinical setting, if that sheet hit the floor, would you want it on your bed? No, because we know that people have, there's pathogens all over the floor. People have accidents and there's all kinds of body fluids hanging around. So if you wouldn't want that sheet on your bed, should we put it on somebody else's? So that's what they're waiting to see is, okay, the sheet hit the floor. That's going to happen in a clinical setting. I guarantee it. 100%. It's going to happen in the clinical setting. But what are you going to do about it? What should we do? Get another one. Yeah, put that one in dirty linen. So for the test, we're not actually going to have to go get another one, but we do have to acknowledge it. Correction, the sheet hit the floor. I would get a clean one. They're looking to see, what are you going to do when? And the people that try to cover it up and hide it and pretend like it didn't happen, those are the ones that are going to put our patients out there at risk. Do we want you guys as CNAs if you're putting the patient at risk? Do you guys see how the test is testing you? What they're looking at here? Does it have anything to do with you? Who does it have to do with? The patient, always the patient. Good morning. So if you can make that switch in your head, the test actually becomes a little bit easier. Good? Good? All right. What do we do with anything that we didn't use, that we took? Discard it. Very good. Scoot and roll. Where's the patient need to be at all times? Middle of the bed. And you may not have side rails to keep them there. In fact, if we are going to use side rails, what do we need? Doctor's order. We don't get to make that call. We don't get to make that decision. But we don't need side rails to keep our patients safe. As long as the patient is in the middle of the bed at all times, we're good. If they are going to turn themselves, they'll do it automatically, just like I showed you, right? I asked the patient to turn over in bed and they scooted, so they stayed in the middle. Your patient will do that automatically. It's your job to look to see, are they in the middle of the bed? But if they can't and we're going to do it, what do we need to have them do before we roll them over? Scoot toward us. That's right. If we have them scoot toward us and then we roll them away from us after the roll, where do they end up? In the middle of the bed. We are going to remain behind the patient's behind. Never turn a patient toward you. It's always away. Some skills require washing. Actually, a lot of skills require washing. This is a big part of what we do. So there's a lot of rules here. What do we not add to the basin? Why? Yeah, we need rinsing water. Absolutely. Can we just turn that faucet on with our hands? Why? Yeah, it's dirty. Our hands are clean. So what are we going to use? Paper towel. We're going to check the water temperature with our, and how should it feel? Warm. Who else has to check it? The patient. If we're going to wash a wet body opening, now we just learned this on Monday. If we're going to wash a wet body opening, we need leaves. Wasn't that cool? A neat way to use a washcloth. So we're going to use the leaves method for any wet body opening. Now, remember, a wet body opening is eyes, nose, mouth, genitals, and rectal area. Those are the ones you're born with. But then there's also wounds, rashes, sores, or incisions. Any unnatural body opening. Okay. Whatever we wash, we rinse. Whatever we rinse, we dry. Say that in your head as you're doing bathing, because you will forget a step if you don't. You just will. And when we're doing all that, since we're working with water, we don't want to get our surface wet. So in most cases, that means that we're going to protect our surface. If it's the table, we're going to protect it with a barrier. If it's the bed, we'll protect it with a towel or a chucks or something underneath the patient. But that also means we need to wring out those washcloths really well so they're not drippy, wet washcloths. Good? Okay. Anytime we use lotion, what do we do with the lotion before we put it on? What do we do after? Okay. And then we have basin cleaning. We clean everything the same way. Rinse it, dry it, store it. Make sure it's dry before you put it back. Let's talk about that for just 1 second, though, especially in a clinical setting. Those drawers are dark. They're also warm. If we don't dry that basin really well before we put it back, what kind of environment do we have? Warm, dark, moist, and what grows there? Yeah, all the bad guys. So do you think drying the basin is pretty important? Because all the other ingredients are there. If we add moisture, we're going to get pathogen growth. So make sure that basin is dry. And then we have shoe rolls. Now, this was somewhat new. This is the newest principle for us We just kind of went over it on Monday. The rest of them we've learned a little longer ago. So this is kind of the new kid. Let's be nice to the new kid. Okay. If the patient's feet hit the floor, we got to talk about their, what does that mean? What does that mean? Yeah. So when a patient, especially for the test, has their feet on the floor, whether they're getting out of bed, whether we're going to walk them, or if we're doing foot care, if their foot is on the floor, we have to say something about the shoes, because the test needs to know that we understand that's important. So if we're doing foot care, we want to say, I'm going to put your shoe back on. If we're going to ambulate a patient or walk a patient, we need to say, I see you have shoes on. We're going to transfer a patient out of bed, which we're going to learn today. We're going to actually put their shoes on and ask, do your shoes fit well? Okay. So we've got to acknowledge those shoes. Are slipper socks enough? No, they don't protect against sharp objects. They don't protect really against slip and falls. They kind of provide a false sense of security, which can be dangerous. So shoes, no substitute for them. Okay. If we're going to use a gait belt, we have a skill today. We're going to use a gait belt on again. We learned one on Monday. But if we're going to use a gait belt, how do we know if it's tight enough? 4 fingers. Can we just put it on loosely and hope for the best? What happens if it's too loose? Yeah, the patient can slip right out of it. Absolutely. Before we lift somebody up, we have to make sure their feet are flat on the floor. And then before we stand them up, we want to make them a partner. So we're going to count to 3 before we lift them so that they can participate. Once we get them standing, we probably should ask if they're dizzy or weak, or, find out if everything's okay while we're here. Don't wait until you're over there. Although we do want to ask as we're traveling as well. Their hands are going to be on your shoulders to keep them moving as a unit. Very, very good. When we're going to sit a patient back down, help them to sit. What do we need to make sure is behind them? Yeah, the chair. It's not enough for us to know. Who else needs to know? The patient. Guys, here's a sad reality. It's a very sad reality. About roughly half of all patients in a clinical setting have been dropped. Think about that. Not all of that results in injury, but boy, does that affect your ability to trust. About half of all patients have been dropped. So that's kind of sad, and it's kind of scary, because some of those patients are going to be injured. But the ones that aren't injured are going to be injured psychologically. And they're probably not going to trust you. Now, you didn't do anything to deserve that, but that's just reality. So by asking the patient to back up so that the backs of their legs hit the chair, that is as much for them as it is for you, because they don't trust you. And in reality, they shouldn't trust you. They should make sure that chair is there. Okay, good. That's a very, very important checkpoint. We want to make sure we're using good body mechanics to help prevent injury. So should I be standing right in front of a patient when I lift them? No, I'm going to stand at an angle, making sure that my feet, one foot is across their feet so it doesn't slide out. The other foot is parallel to the chair. This puts me at an angle, so I have more leverage when I lift. Okay, good. And then we have the closing. Every skill ends the same way. There's a whole lot of C's up here, but we want to make sure that the environment is clean. The bed is in the low position. The patient is comfortable and covered. Yes, very good. Comfortable, they need to hear that word, right? But they also need to hear that we understand emotional comfort. So what are we going to offer them? Yeah, magazine works. Sure. It's the simplest way to address that for the test, keeps everything uniform. But in a clinical setting, it's probably going to be more like, do you want your phone? Do you want the TV on? We aren't passing magazines around in a clinical setting usually. Once we get all of that done, you know, the environment's clean, the patient's covered, bed's in low position, the patient is comfortable. What do we want to give them? Call light, and that call light needs to be in their hand. And if there's a weak hand, it's got to be in the strong one. That's right. So keep that in mind. Don't just point out the call light. Most of the standards say in or near the hand, but there are a few that say in the hand. So I just like to make things simple. For the test, put it in their hand for all skills, covers all bases, right? I always tell patients how to use it because patients are usually medicated. They may not remember how to use that call light. So press the red button if you need me. After we've done all that, we're probably going to open the curtain. Doesn't matter when you do that. You can open the curtain before you give them the call light if you want to. But all of those things have to be done before we clean our hands. If you go back to the patient, what do you got to do again? Wash your hands again. If we have to chart, that happens after hand washing. So we wash our hands, we chart whatever we need to, and then what do we need to do? Because our standard is in skill with clean hands. Good job. So pulse, I'm going to go through this really quickly. We're always going to support the arm. It's always reported over 1 minute. We're going to follow the care plan for how long to count. Normal is between 60 and 100. We're going to use our fingertips, not the flat areas of our finger, and we don't use our thumb to take the pulse. Radial pulse is located on the thumb side of the wrist, the top of the thumb side of the wrist near the bone. We'll say start and stop for timing. In Florida, we count with 2 evaluators. Because we count something, that means we have to document. When we dress a resident with a weak arm first, we're going to ask about clothing preference, and we get the clothing before we undress the patient. We lift from below with a flat palm, supporting all joints when lifting. We undress strong arm first, dress weak arm first. Don't overextend or force movement. Adjust clothing. Put your dirty items in the hamper and the call light in the stronger hands. Hand and nail care. We're going to support the wrist and arm at all times. You starting to notice a pattern there? All right, we're going to soak the hand in water. Whatever we wash, we rinse. Whatever rinse, we dry. We place hand on a towel. We'll use a beveled edge to clean under the nails. And we'll wipe that orange stick off on a towel in between each finger. Emery board files in one direction only, and we apply lotion last. Making an occupied bed. Patient's going to be on their side in the middle of the bed when we change the bottom sheet. So we got to get them there. So scoot toward me, roll to the center. We're going to roll that bottom sheet toward the patient because dirty rolls away, right? Clean rolls toward me, dirty rolls away. We'll remain behind the patient's behind and try to remove as many wrinkles as possible. We'll make hospital corners, loosen sheet over the toes. That was a good catch on Monday. And we'll replace the pillowcase with the opening facing away from the door. Sideline position. It's all about proper positioning. So if we get our patient prepped before the turn, there's no effort here at all. We'll scoot the patient toward us. Furthest arm goes up. Closest arm crosses over. Closest knee is bent with the foot on the bed. Furthest knee is angled out. And now your patient's ready to turn. It takes no effort to just turn their torso on the side. We're going to put a pillow behind the back, between the legs, under the upper arm. Adjust the pillow under the head, and the call light goes in the bottom hand. Look how much we've learned. Foot care, just like hand and nail care, a little bit lower. We're going to soak the foot in a basin of water. Once we soak it, we're going to take it out while supporting it and put it on a towel to wash it, put it back in the basin to rinse, put it on a towel to dry. We're going to wash all areas, but we only lotion everywhere but between the toes. We'll put the shoe and sock back on, making sure the sock is on correctly, that the toe seam is right, and the shoe is secured properly. Brushing teeth. You guys know how to do this. You brush your teeth pretty regularly. So patient must be sitting fully upright. We're going to protect that clothing, wet the toothbrush before applying toothpaste. We'll brush all surfaces and the tongue. We're going to allow that patient to rinse and spit as often as they need to and leave their mouth and clothing dry at the end of the skill. Counting respirations. We don't want to tell them we're counting respirations. It alters their breathing. So respirations are always reported over 1 minute. Normal is between 12 and 20. We're going to say start when we start to count, stop when we stop counting. In and out is counted as 1, and this is a documentation skill. Range of motion. Remember, CNAs do exercises to retain function, not regain. We're not trying to make anything better, so we don't do pain. We're going to lift extremities from below with a flat palm, 2 points of support near the joints. We're going to move slowly and smoothly and always return to start. Flexion extension is up, down. Abduction, adduction is side to side, and rotation is round. We'll always follow the care plan. Denture care. Denture care has 2 parts. We clean the dentures and the mouth they came out of. That means this skill requires 2 sets of gloves, one for the dentures and one for the mouth. So we're going to line the sink with a washcloth. We'll use cold water. We're going to store the dentures in a clean denture cup in water on a barrier, on a paper towel, on a coaster. The patient must be sitting fully upright. We're going to protect the clothing, brush all surfaces in the tongue. We're going to rinse out the brushes. Rinse out the denture brush and store it. We throw away the toothbrush. All brushes need to be wet before we put toothpaste on them. We'll allow the patient to rinse and spit and leave the resident's mouth and face dry. Ambulate with gait belt. Remember, this is our most important thing is eyes on the patient. Pay attention to them. We're going to put the gait belt on while the patient is sitting. It goes around their waist, over their clothing. Did I tell you this story? I didn't tell you this story. We were talking about common testing mistakes, right? So when we were a testing center, one of the evaluators came out and said, "You're not going to believe this one." Okay. I was never an evaluator because you can't be a teacher and an evaluator. You have to pick one, and I'm much better as a teacher. Because if I'm an evaluator, I want to explain to you why you did something wrong and how to fix it. Evaluators are not allowed to do that. They cannot give you feedback or instruction. So I wouldn't make a good evaluator. It would drive me nuts. So the evaluator comes out and she says, "You're not going to believe this one." I said, "Okay, what?" She said, "So this girl had ambulate with a gait belt and clearly didn't know anything about gait belts, hadn't been trained on them, didn't know the first thing about them, and didn't know how to use them. So the first thing she did was put the gait belt around her waist and have the patient hold on to it. And then she thought, nah, that's probably not right. So she took it off of her and put it around the patient's chest and started to pull up this way. And the evaluator was just about to stop her, and she stopped herself. And I guess she figured that wasn't right either. So she took the gait belt off and asked the patient to lift their clothing up to put it around their waist. And the patient's like, "I don't want to lift my clothing up." So the evaluator had to stop the skill and say, "That's not, please don't." Or she says, "Please don't have the patient disrobe." And the CNA or the candidate was trying to figure out how to get the gait belt around both of them at one point. So there's a lot of ways that you can mess this up, and this candidate did all of them. So if you don't understand the gait belt, please go back and watch that video, because this skill has a high rate of injury. And we really don't want to hurt our patients. There's a lot of ways this can go wrong. Please remember the gait belt does go over the clothing around the patient's waist. And we always lift from the sides or the back. Never pull from the front, because that's going to cause the patient to do this, which alters their center of gravity and makes it much more likely for falls. We're going to help them to stand by holding the gait belt around the sides or the back. We're going to let our patient lead, holding that gait belt as an underhand grip from behind. They should be slightly in front and to one side so that they are in your field of vision at all times. What should we be watching for? Yeah, anything abnormal, dizziness, sweaty, pale, hand out, up, or stomach, wobbly, anything that just doesn't look right. If they're not walking normally, we're not walking. We're going back. Well, if they are not walking normally, should we hurry them back? What should we do with them? Send them on the floor. So yeah, if they can make it back, if they're feeling okay, we'll make it back to the chair. But if not, if I have any concerns, we're not making it, I'd rather them sit on the floor than fall. Right? All right. So ask them how they feel as we're walking. We're going to assist our patient when they stand and sit, and don't pull that gait belt across their skin because that can leave a burn. We learned partial bed bath. This is the longest skill. 19 minutes they give you to do this one. It is a really long skill. We're going to wash face to waist, front and back with one arm. We're going to wash the face first, no soap on the face because soap stings when it gets in the eyes, dries out the skin. We're going to use the leaves method, and we're going to control that washcloth as we wash. So no floppy corners anywhere. We want to make sure that washcloth is tucked very well into our hands so we have control over it. We're going to use one leaf for each wet body opening the patient has to prevent cross-contamination. We'll support the arm at the elbow when lifting. We'll change the water if it's cold or soapy. We're going to turn the patient on their side to wash, rinse, and dry the back. Give them a brief back rub with long strokes and lotion, and apply a clean gown at the end. Wow. 3 weeks. Look at all you've learned. Has it been hard? No, but you've learned. You've learned a lot. Fair warning for those of you going on to nursing. Nursing school does not work like this. Nursing school, they bury you in information, and if you dig your way out, then congratulations, you're a nurse. They don't spoon feed you. So I like to make that known because a lot of students that start out in my classroom, about 60% of students that started out in this classroom go on for nursing. Right now, we've got one a former graduate from this classroom who now has their doctorate in nursing. We have about 15 that have their master's degree and are nurse practitioners. And we have a whole lot that, I've been doing this for 17 years, guys. And we have a whole lot that are RNs and LPNs. So those are just the ones that come back and have told me. I'm sure the number is probably a little higher than that, but about 60% of my former student base has gone on. So please bear that in mind. I make this easy. We're forming a foundation. But the education that you're going to get from this point on will be much faster paced and not quite as explanatory. Okay, good. See, I could give you all the information from the yellow book. I do most of it in class. So the yellow book is more reinforcement. But the reason I still have you read is because I know some of you are going on for nursing, and you need to develop those good study habits now while it's still easy. Okay. All right, so we're going to learn how to transfer from bed to wheelchair. This is on page 72 of your book. Nothing to learn here. We've now mastered every principle on that back wall. There is nothing new to learn. That means that this skill is going to recycle what we've already learned. We're just going to apply it to a new skill. So, of course, skill rules always apply. We follow the care plan. We always do the opening, doesn't matter what the skill is, and we evaluate for gloves. Doesn't mean we're going to have to use them, but we always evaluate for gloves. Shoe rules are going to apply to this one, so all of those shoe rules that we just went over. And the closing obviously applies to every single skill. So what we want to focus on now are the skill-specific steps. And that's what we're going to get into with this particular lesson. Now, along the bottom, you can see test-specific information. This skill should take somebody with your level of ability 11 minutes or less to do. You're transferring somebody out of bed and into a wheelchair. It doesn't take 11 minutes. This is going to be done on a real live testing patient or testing student. That student will start out in bed and charting is not required. But let me explain to you how this works for the test. When you go in on testing day and they check you in, they're going to ask you, do you have any conditions that would keep you from being a patient for any of the skills? Now, if you just had dental work done and you've got, stitches, you need to let them know, hey, I just had some dental work done. You're not going to be a patient for mouth care or denture care. If you've got athlete's foot on your feet, you're not going to be a patient for foot care. If you are allergic to milk and applesauce, you're not going to be a patient for feeding, which we're going to get into in a few minutes. So we need to be aware that you are also going to factor into the test your own unique situations as to which patient or which skill you can be a patient for. Does that make sense? Everybody with me? All right. So when they pair you up, they're going to look at very specific criteria. So if you get transfer from bed to wheelchair, okay, you need a patient. We know that it's a real patient. So you need a patient to do that on. Well, they're going to try to find somebody out of the people that showed up that's your body size or smaller. Okay. They're not trying to set you up to make it harder. So they're looking for somebody with your body size or smaller. And they're even going to go a step further and try to pick somebody who has slip-on shoes to make this even easier for you. Because you have to put shoes on them. So where do those evaluators want to be? Home in their pools, drinking their Mai Tais. They don't want to be watching you tie shoes, right? Because they're harder to get on, take a little bit more time. So if you get this skill, she would be your patient because she has slip-on shoes and she is about your body size. So they're going to pair you up using this criteria. And this is why it takes a little bit of time. If you've got 8 students, they all have different skills and you've got to work around their own personal problems about being patients. So it takes them a little bit of time to pair you up. Please remember that pairing process is not random. Don't try to make this harder for the evaluators than it needs to be, though. Okay? So if you don't like people messing with your feet, don't tell them you have athlete's foot to get out of being a patient for foot care. Okay? Don't make this harder than it needs to be. Good? Okay? All right. So all of our instructions are on page 73. At the bottom of the page, you'll see the supplies for this particular skill. And at the top of the page, we have the care plan. Okay. So let me go back here. We've got a couple of comments and questions. Joe Bengal says, my family's definitely tired of being called Mr. and Mrs. Jones. Good job. That tells me you're practicing. Good morning. Vanessa says, is a disability wheelchair different from a regular wheelchair? We're going to talk about wheelchairs. What's that? Yeah. Yeah. Yeah, I think we're pretty big in the Midwest. All right. And does the patient's shoes have to be closed or can they be sandals since I live and I'm watching from Arizona? There you go, Midwest. Yes. So good question, Vanessa. On the test, you need to make sure that you are wearing closed-toed shoes. Slip-ons are fine. Your shoes are fine. Your shoes are fine. Everybody in here is good. No sandals, no flip-flops, nothing that doesn't cover the toes. Make sure that they're closed-toed, okay? And then we'll talk about different wheelchairs in a minute. We have a congratulations here, Lucille. Good morning, Miss Patty. This is Lucy. I took the state exam on Monday and I passed. Thank you so much. Congratulations. That's so exciting. Good morning, Anthea. All right. So our care plan at the top of the page here says to transfer the resident from bed into the wheelchair. The resident is unable to walk, but can take, or unable to walk or take steps, but can stand with support. So let's stop there for a second. That means this patient can stand with help, but when we turn them to sit them in the chair, they cannot take steps. So that means that the wheelchair is going to have to be super close to this patient. And when I say super close, I mean this far from the patient. Because when you stand somebody and turn them, that chair has got to be right behind their legs so they know it's there before we sit them down. Remember how that was an important step, them knowing it was there? A gate belt or transfer belt is required to transfer the resident, and the resident will stay in the room after the transfer. So this isn't the end of this patient's day. You guys know that, right? This is like a scene of a movie. Yeah, so it's like a scene of a movie. The movie doesn't end. It's just a scene. So we're going to get the patient sitting in a wheelchair, and they're going to stay there, but the scene ends. Now, if you guys were stuck in a wheelchair in a room, would you want to be facing a wall? No. What would you want to be facing? Window, door, TV, something. If you put a patient in a wheelchair and leave them facing the wall, they're going to feel like they're being punished. You guys are all young. Oh, I'm getting older every day. You guys are all young. Used to be, years ago, a very common punishment when you did something wrong was to stand in the corner or stand against a wall, right? So most of our patients that we're going to deal with are older. If you leave a patient staring at that wall, what are they going to feel like? They're being punished. So this doesn't sound like a very big step, but it actually is. Making sure that you turn that patient so they're facing out is a big step on the state exam. You guys understand why? Okay. All right. Let me get my drink. Hold on one second. Okay, so wheelchair 101. So this skill is going to involve shoe rules. So if we remind ourselves of shoe rules, if the patient's feet hit the floor, we got to talk about their shoes. In this case, we're actually going to put shoes on the patient physically. Put shoes on. I don't want to run anybody over. We're going to physically put shoes on the patient. But when we do that, we want to make sure that they fit correctly. Because in this skill, it's really easy to get into a hurry. And if your patient's shoes aren't on right, when you go to pivot them, because remember, we're swinging them around. If their shoes aren't secure on their feet, when we go to swing them, the shoe will stay in place and the foot will turn. Does that make sense? So you really got to make sure that they're secure on the feet. Slipper socks are not enough. We do have to physically put shoes on the patient. 4 fingers between the gait belt and the patient, and the feet must be flat on the floor. We'll count to 3 before we lift them. Ask if they're dizzy or weak after standing. So lift them up. We're going to spin them, make sure they can feel that chair, make sure they feel okay, and we're going to sit them down. Okay, good. Don't pull the gait belt across the skin. So our shoe rules are going to apply to this. This is going to go through each one. Hold on. So no oblique angle before you sit the patient. They must be able to feel it. says that they're unable to walk or take steps. This is where I needed to get to. So because this patient is unable to walk or take steps, we can't have the wheelchair too far away. If we stand that patient up to get them in that wheelchair, they have no choice. They have to take steps to get there. Otherwise, they're going to fall. But our patient can't. So that means during this skill, we've got to get this wheelchair way up here, super close to the patient, and make sure it's locked in place. Good. That's the #1 mistake that's made on this test, on this skill, is the wheelchair is too far away. So let's talk brakes. So this is this wheelchair, these pictures. And different wheelchairs operate a little bit differently. There's all different kinds of wheelchairs. If you go onto Google and you search wheelchair images, there will be over 1 million images, and they're all different. All of them are different. Some are black, some are red, some are gray, some are yellow, some are electric, some are companion chairs. Companion chairs, see these little wheels on the front of this wheelchair, these little tiny wheels? Yeah, those, a companion chair has 4 little wheels, and they're lower, and they're specifically designed for, have you ever seen little old people that just kind of shuffle along in their wheelchairs? They use their feet to kind of go everywhere. That's what a companion chair is for. It's lower to the ground, and it allows the patient to, we call that pad around with their feet. And they're more maneuverable. So companion chairs, which might be what you were referring to, are a little bit different, but they operate in much the same way. Okay, it's a chair with wheels. Leg rests and foot pedals, we're going to get to in just a minute. There's also wheelchairs that can be configured for specific types of disability with different limb holders or bracing or things like that to keep our patients safe. So there's a lot of variation here. When you go take the test, they're going to be using a wheelchair similar to this, which is just a basic wheelchair. When you go take the test, if you get this skill, they're going to go over how to work that wheelchair. It'll be part of your orientation before the test even starts. Remember I said on day 1, they take you in and show you where everything is? Well, if you have transfer, they're also going to show you how to use the wheelchair. So just a brief understanding of how most wheelchairs work. They usually are kept in the folded position for storage. It keeps them smaller. But you can't really, it's hard to push them when they're in this position because those front wheels, see how they get all tangled up with each other, right? So if you're going to be moving a wheelchair that's folded, if you tip it up to get those small wheels off the ground, it makes it easier to maneuver. So there's a little tip for you. When you're moving a wheelchair that's folded, tip it up to get the small wheels off. So to open a wheelchair, you simply open the handles. There's no trick to it. There's no button to push or lever to pull or anything like that. It's all manual. But these big wheels, because they're on the floor, they're going to have friction, and you're going to be trying to push against that friction. So if you lift the wheels off the floor just a little bit, doesn't take much, just a little bit, and open it up, it opens much better. To close a wheelchair, you lift up on the center of the seat, and the 2 halves go back together. So if I don't lift the handles, it takes a whole lot more force. You guys see that? Where if you lift, super easy. So there's a little secret, okay? Now, wheelchairs, the most important part of this wheelchair are the brakes. The most important part are the brakes. So there's 2 different types of brakes. There's one that you push forward, and there's one that you pull backward to engage the brake. They work the same way. It's just, do you push it forward or pull it back? When you go to test, they're going to train you on their wheelchair. But here you can actually see how brakes work. So I've highlighted it for you. This is the metal, what we call the lever, the brake lever. And then this is the surface of the wheel. There's a gap here, which means the wheel will roll freely. These brakes are off. By pushing that lever against the surface of the wheel, it stops the wheel from rolling, and now the brakes are on. So this particular wheelchair, forward is brake off, back is brake on. Now, the other wheelchair I have in the supply closet is just the opposite. You have to push it forward to engage the brake. So you want to make sure that you understand that brakes are going to be applied differently for different wheelchairs. But brakes are truly the most important part of a wheelchair. And anytime that we walk away from the wheelchair, if it's not actively in motion, the brakes should be on. Floors are rarely level. Rarely level. In Florida, we build on sand. Sand shifts, and all of that concrete tends to buckle. Okay, so your floors are not level. In fact, I've got an unlevel area over here that if I put the wheelchair in that area, I have to find it. But if I put the wheelchair in that level, it'll start to roll. It's somewhere over here. It'll roll like all on its own. So floors are rarely level. Up north, they use wood floors. Those warp. So again, rarely level. So if I've got a wheelchair that has a body in it and it starts to roll all by itself, the only thing that's going to stop it from rolling is whatever it runs into. Okay, make sense? So if we have a body in the wheelchair, it should be locked. That's safety. If the patient wants to go somewhere, the locks are right there. They can unlock it, go anywhere they want to. It's not a restraint. It's a safety measure. Good. This was actually the largest lawsuit in Florida. Had to do with this. A dementia patient was strapped into a wheelchair with a seatbelt. And by the way, they did not have an order for that. That's a restraint. In 2004, that dementia patient was able to access a stairway door and fell down a fire escape stairway, concrete and metal steps, and died. Yeah, because the wheelchair was not locked. Safety. Think about why we put patients in facilities. Why don't we keep people at home? Why do we put them in a facility? Okay, for safety. What was that? Help, yeah. Yeah, so if I'm working, how can I stay home and take care of grandma? Right? Nobody's available. We need help. Even if I'm home and I'm untrained, I may not be able to take care of grandma the best way possible because there's a lot of things that you didn't know 3 weeks ago that are now common knowledge to you. Right? So we put people in facilities to provide necessary care and ensure their safety because those people are supposed to know more than we do, right? As family members. So what is the point of putting a patient in a facility if they're going to be injured due to negligence? Now remember, those facilities cost money. Nursing homes cost anywhere between $6,000 and $9,000 a month out of your pocket. It is not paid for by anybody but the patient and their family. So anybody here have an extra $6,000 a month you'd like to give me? I don't even have $6,000 a month. So why are we paying staff members if they're not going to do what we're paying them to do? Does that make sense? So I agree with this lawsuit. I agree with this. They should have been sued. Absolutely. Because if it was my family member, I want you to think about that for a second. You've got a dementia patient strapped into a wheelchair that is getting closer and closer to this stairwell, and they can see it coming, and they can't stop. because they don't remember how. Now, even though they may not have a memory, they still understand fear. Can you imagine the psychological distress that this would cause right before they died? I'm sure that patient is haunting that facility. And whoever did it. Make sense? What we do matters. So this was a cascade of failures. Of course, there was no brakes on the wheelchair. The door was left unsecured, so the dementia patient was able to get to an area they should not have been. This is a cascade, not properly monitored, right? This is a cascade effect. Usually, catastrophic events are not just one single failure. It's a cascade of failures. But we are a link in that chain, and we need to be aware of that. Good? Wheelchair brakes are not a restraint. They are a safety measure. Anybody that is in a wheelchair that is able to self-propel, they can take the brakes off, go anywhere they want to. If they're not able to self-propel, it means they're not able to self-stop. Brakes need to be applied. Good? All right. All wheelchairs should be locked when not actively in use. Let's talk about wheelchair height. So what you see here, my class can actually see in front of them. Okay, so you can actually, this is exactly what you're seeing here. But I want to point out that there is a height difference in the seats. See how this chair is much lower than that one, that seat? And that's specifically because wheelchairs are designed to make somebody mobile. Regular chair, we want their feet flat on the floor. Wheelchairs, we don't, because we want to push them somewhere. If their feet are flat on the floor, we can't push them effectively. Make sense? All right, but that's a problem. It's a real big problem, and one that nobody really talks about. So let's talk about it. All right, hold on. Couple questions here. How about if the patient wants to choose their own shoes? Absolutely. Patients have the right to choose their own shoes, put them whatever they want on, as long as they're, hard-soled, that, they have some traction to them. I watched your previous video on this lesson, and you mentioned to underline unable to walk and not able to take steps. Yeah, absolutely. That's going to be an important part of this particular lesson. I've been up since 4 a.m., just got your class. And can you have another CNA help you if the patient is shorter and taller with a lift? Again, you're going to go by your care plan. Go by your care plan. I can't give specific information on each patient that you might encounter out there because there's so many different options. Let's talk about this. So because our patient is in a chair that's higher, their feet are going to dangle. Well, along the back of our legs, we have arteries and veins. And the arteries are going to push the blood down to the feet, and the veins are going to bring the blood back up to the heart. But going up is against gravity. Against gravity. So that means that as the blood has to climb from my feet back up to my heart, it's going against the flow, against gravity. So inside our veins, we have little, hold on, I'm going to come back. We have little flaps inside the vein. So as the heart beats, it pushes this blood up into this chamber. The next heartbeat would push it back up into the next chamber. The next heartbeat would push it up into the next chamber. Make sense? Everybody got that? Okay. So when we're sitting in a chair and our feet are dangling, not touching the floor, this seat edge is going to press up into those veins that are running in the back of your knees. They compress those veins. So when they compress, that means the blood can't get pumped beyond that point. So we end up with swelling. Do you guys see that? You end up with swelling. So when we have a patient sitting in a wheelchair and their feet aren't supported, they're at risk for developing swelling. But it gets worse because it's not just the swelling that's the problem. When blood slows down or stops, it clots. See how this is all clotted together? That's because it can't get past that point. So not only are they at risk of swelling, they're also at risk of blood clots. So we've got to understand this so we can learn how to prevent it. And that is what foot pedals are all about. So when you have a patient in a wheelchair, if you don't get those feet on foot pedals to support them, if you just let their legs dangle, you're actually putting them at risk. Now, these foot pedals are removable. They just lift off. They're removable. And that's a problem because night shift is going to clean these wheelchairs. And they're going to take these off and clean them, and then they're going to put them somewhere. And the next morning, you go to get the patient in the wheelchair, and there are no foot pedals. Don't ignore that. Don't think, I'll get them later. Remember, you're setting your patient up for risk factors. Go find the foot pedals. They are important. And they just sit, these foot pedals just sit on these little prongs. They're right there. Just sits on the prongs. Okay. Good. They're super easy to take on and off. The problem is they get lost a lot, especially because night shift loses them. All right, so we have leg rests and we have foot pedals. So we're learning about the different parts of the wheelchair now. You have the seat, armrests, leg rests, and foot pedals. So the leg rests actually swing out to the side like you see here. If I'm going to get my patient's feet on the leg rests, we're going to swing them forward. Now listen to the click. Hear that? They're now locked in place. They don't go anywhere. That's the position they need to be in for our patient to be able to support their feet. But you can't get a patient into or out of a wheelchair with these leg rests in place because they're going to trip over them. So right here behind is a catch. You just pull the catch and they swing back out. So right here, for those of you who are playing along at home, right here, this little metal bar right here is the catch. You simply pull it forward and the leg rests swing out. Good? Good. So these are the three configurations of your wheelchair. This is when a patient is in it. Leg rests are forward, foot pedals are down, patient sitting in the wheelchair. These are supporting the patient's legs. Good? Patient in use. This one is for storage. We fold the foot pedals up, but the leg rests remain forward. And we fold the wheelchair by pulling up on the seat. So stored. This is for transfers. We need those leg rests out and the foot pedals up, just like you see now, for transfers. Good? Okay. You may have a question on the state exam that gives you these pictures and says, which of the following configuration is appropriate for a wheelchair to be in during transfers? You would want to pick this one. You do not want the foot pedals or leg rests to trip our patient. Good? Okay. Because that was another lawsuit. We're going to get to that. Oh, here it is. So a lawsuit in Georgia occurred because a worker allowed a patient to get out of a wheelchair without repositioning the foot pedals. Let me explain what happened here. This is a case of somebody was trying to do a good thing. No good deed goes unpunished. Anybody ever hear that? Okay, this was a clerical worker, like a registration person. And the patient's daughter went to get the car. She had been there for testing, older lady, patient, been there for testing. Daughter goes out to get the car, pulls it around front, and the mom is going to leave. Okay. Well, the person that was supposed to take the patient out and get her in the car had to go somewhere. She left. So we got a registration clerk, a patient waiting to leave, and a car right outside the front door. Blocking entrance. So the registration clerk's like, no problem, I'll help you. She's trying to be helpful. So she takes the patient in the wheelchair out to the car, but she had never been trained on how to use a wheelchair. This was not in her scope of practice. She was being nice, but it wasn't in her scope of practice. And she did not know that you have to move the foot pedals and the leg rests before you transfer the patient. So she just took the wheelchair with the patient in it out to the car, and the patient tried to get up and into the car, tripped over the foot pedals, fell, and broke her leg. Is she going home? No. Nope. Broke her leg. Yeah. So that was a lawsuit in Georgia over this. So anything that prompts a lawsuit, you can guarantee is going to be on the state exam. Why? Why? What's that? They don't want it to happen again. We learned that this is not a good idea. So we want to make sure that you don't do it either. Good? Make sense? That's why I bring these situations up. All right, so we're going to prepare the wheelchair by moving the foot pedals up and the leg rests out so that when you go to transfer a patient, the wheelchair should look like this. Okay? Once we get and locked, it has to be locked. If I don't lock the wheelchair, if I get everything out of the way and I go to put somebody in it and it's not locked, what's going to happen? Yeah, it's going to roll. So always locked. Remember, if the wheelchair isn't actively in use, it must be locked. All right. But we're going to position the foot pedals up and leg rests out. Once the wheelchair is prepared, we'll pivot the patient to sit on the side of the bed. This is not nearly as hard as you think it is. I'm going to show you how to do this. That's actually makes it pretty easy. Once we get them sitting on the side of the bed, we'll put their shoes on. And then we have to make sure their feet are flat on the floor. And then we're going to get that wheelchair super close. Do you see how close that is? It's almost touching the patient. Yeah, we need it that close. If you can fit an entire fist between your patient and the wheelchair, it is too far away. Okay. We want to make sure the brakes are engaged, the foot pedals and leg rests are out of the way so that we can transfer. We'll make sure that wheelchair is locked. We'll apply the gait belt around the waist and check with 4 fingers. Now, it doesn't matter whether you do the gait belt first and then bring the wheelchair over, or bring the wheelchair over and then put the gait belt on. Nobody cares. Just make sure it's all done before we try to lift the patient. We're going to use that same body mechanics. Their hands on our shoulders. We'll reach around the back or the sides of the gait belt. And on the count of 3, we're going to lift, spin, but they have to tell us that they can feel that seat. Now, it says our patient can't walk or take steps, but can stand with support. But I don't want to be standing there holding that patient up. Right? Imagine that for a second. I lift the patient, I spin them around, and I go, can you feel the chair behind you? And they say, yes, I can feel the chair behind me. And I say, okay, we're going to sit now. That's a long time for me to be holding that patient. So instead, I do this. I tell the patient before I ever lift them, I'm going to lift you up and spin you around. When you feel that chair behind your legs, please say sit. And then I have them put their hands on my shoulders, grab the gait belt, and I'm going to say, remember, when you feel the seat behind you, say sit. Ready? 1, 2, 3, up, over, sit, sit. It's a whole lot quicker. Good? So a little bit of preparation could save you a whole lot of time and effort. All right, so we're going to use proper body mechanics. We're going to lift with our legs, not our back. And we're going to pivot the patient smoothly without them taking a step. I want to point this out. This is me. He is 6 foot. This is me. I am clearly not 6 foot. Can you transfer somebody bigger than you? Yes. I'm doing it right here. Yeah. You can, as long as you're using the right body mechanics. Now, if I feel that this person is beyond my physical ability to transfer safely, should I try to transfer them anyway? What should I do? Yeah, tell the nurse, hey, I don't feel like I can transfer that patient safely alone. So they either will get you some help, or they will amend the care plan to maybe use a mechanical lift. The whole point is to keep our patients safe, right? Now, me, I've been doing this for a very long time. I've been a nurse long time, longer than most of you guys have been alive. Okay, so I can lift, I can move, I can move any of you guys easily, because I've developed the muscle strength, and I know it doesn't look like it, but I do have a lot of upper body strength, and I know my limits. I've tested them. I've learned through my life. I know when I'm not safe as well, and I know enough to ask for help, because at the end of the day, it doesn't do me any good to transfer a patient that I don't feel comfortable transferring and cause them injury. That's a whole lot more paperwork. Or injure myself, yes. Good? Questions? Okay, so we want to make sure they can feel that wheelchair behind them before we sit them down. Make sure their feet are on the foot pedals and the leg rests are in the forward position, and then we can remove the gait belt. We're also going to lock the wheels. It doesn't matter what order you do those steps in. Doesn't matter what order, but you do need to turn that wheelchair around so it's facing away from the wall at some point. But if you go back and remember, let me go back here. Remember this, right? We can't bring this leg rest forward with a wheelchair in this position. It's up next to the bed. There's no room there. So we know we have to move this wheelchair to get that leg rest and foot pedal. So while we're moving the wheelchair, just turn it all the way around so it's not facing the wall. Good? Okay, I gotta find out where we were. There we go. So we want to position, ensure the patient is positioned properly in the wheelchair, and then do our closing. So any questions on that? Now, normally I do this one in person in front of you. I'm not going to today because that turn, my knee isn't going to handle it today, and I'm very sorry. So I am going to show you the video on this one, but I normally do this one live. I just can't today because I'm hurting. So bear with me. Yeah, Vanessa, yeah, I agree. I see a lot of people with the transferring individuals with the foot pedals. Yeah, I've seen it too. It's very sad. Don't do it. Don't do what they do. Don't leave the foot pedals in place because your patient will suffer. So let me get the video going here.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to get you up and into a wheelchair. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get your supplies, and I'll be right back.
Okay.
Okay, Mr. Jones, I'm going to pivot you around so you're sitting on the edge of the bed. I'll need you to scoot toward me first, if you would, please. Okay. And I'm going to ask you to cross your arms over your chest. I'm going to put one arm behind your shoulders. Maintain a wide stance and put the other arm over your knee. And on the count of 3, I'm going to pivot you. Ready? 1, 2, 3. Are you comfortable?
Yes.
Okay. Can you sit up straight for me, please?
Yes.
Are you dizzy at all?
No.
Okay. I'm going to assist you in putting your shoes on. Are your feet securely in your shoes?
Yes.
And are your feet flat on the floor?
Yes.
Okay, let me get a gait belt. I'm going to place this gait belt around your waist, and this is going to help me lift you and pivot you into the wheelchair, okay?
Okay.
I'm going to place this around your waist. Go ahead and raise your arms, and then you can relax. We'll make sure that there's 4 fingers between the gait belt and the patient, and then lock it into place in the second guard. Let me get the wheelchair. I'm going to position the wheelchair next to the bed so it's at a slight angle, almost touching the patient. And we'll lock it into place. Okay, Mr. Jones, can you bring your feet together? And slightly back. Thank you. I'm going to ask you to put your hands on my shoulders. On the count of 3, I'm going to lift you, pivot, and sit you down in the wheelchair, okay?
Okay.
Go ahead and put your hands up here. And on the count of 3, 1, 2, 3. Thank you very much. Are you comfortable?
Yes.
Okay, I'm going to remove the gait belt. Can you lift your arm, please? Thank you. Okay, I'm going to unlock the wheelchair and swing you around. Okay, Mr. Jones, I'm going to lock your wheelchair in place. And then I'll position the leg rests and foot pedals to support your legs. I'm going to lift your foot. I'm going to lift your foot. There you go. Okay, Mr. Jones, here's your call light. If you should need anything at all, please let me know. Are you comfortable?
Yes.
Can I get you any reading material?
No, thank you.
Okay, I'm going to open your privacy curtain and wash my hands. Thank you.
Thank you.
After washing my hands, I'll think about all the steps of my skill, make any corrections, and tell the evaluator my skill is done. Okay. So, Vanessa, does it matter with medical conditions to leave the foot pedals down? Again, you're going to go by the care plan for that patient. I can't give you one answer that's going to, cover every single scenario that you might find yourself in. And I know you're taking CNA classes in order to work with disabilities, and that's where your focus is. And I understand where your questions are coming from. But you're better off sending those questions to the nurse that's caring for those particular patients to get specific guidance on that specific patient. Okay? Questions? No? Everybody good? Okay, so we're going to go ahead and take our break just a little bit early today because we're going to get into feeding next, and that takes me about an hour to go over. I know, feeding. What is there to cover with feeding? But there's a lot that we have to go over with feeding. So it's going to take me about an hour to go through that lecture, and I'd rather do the break before than after, okay? So let's go ahead and take a break and come back in 15 minutes.
Super crazy. I wish I could remember you from either. I don't think. No, yeah. Yeah, that's crazy. Wow. Yeah. That's cool.
Super wild.
That's cool. So you've been up over there since? Like, yeah. Yeah. I don't think it's
Okay, anybody have any questions for me? And Lisette, I know you're watching. I got your message. The next CPR class will be on Monday, this coming Monday at 2 p.m. And we'll see you in class. I'm sorry you're not feeling well. Okay, Anthea asks, can you raise the head of the bed and put the patient in the sitting position? Yes, you absolutely can, if that makes it easier for you. The thing is that it usually doesn't make it easier for you. You think it's going to get the patient sitting up so that you can swing them around. But the problem with that is that you lose momentum. By taking the patient from a laying position, as you're swinging them, they get momentum to sit up. So you're decreasing the arc, the amount that you have to turn, that you have to sit them up and turn them. You're decreasing the arc, which you would think decreases effort, but it actually causes more effort because you lost momentum. So yes, you can put the head of the bed up. There's no problem with that. Just remember that it may make it harder for you as well. Give it a try each way. Some people do well with it. All right. Any questions before we move on? Any questions? Okay. I wanted to show you guys this. I haven't talked about these yet because we just got them. And this is brand new, hot off the presses, literally. You know these things that we use, the yellow cards, right, with the care plans? And you have these in your book on page 25. You know, the care plan sets, right? So I made these up to go in the practice kits, these kits. So the practice kits is all about skills practice. So everything you need to practice the skills is in the kit. So I made these up to go in the kit. We just got them. But this is all of those care plan sets in a card form on a ring. And I was just going to keep them in the set. So if you wanted them, you had to buy the whole kit because it's part of. But I think that I'm probably going to allow you guys, my classroom people, to purchase them if you want to. I'll be selling them, I don't know, $5, so if you want these, let me know. I'll have them available to you. I'm not going to open it up for virtual people though. This will be in the kit because it's going to cost me way too much to ship this anywhere. So I'd have to charge you like $1 bazillion. Shipping rates are getting unbelievable. Unbelievable. So for you guys that are sitting in the classroom, if you want these, just let me know. We will have them available for you. For those of you who are joining virtually, if you want them, they'll be in the kit by the practice kit. Okay. So I'm going to sit for this next segment because we're going to be talking about feeding a resident. This takes me a little bit of time to teach you. Can you guys see me? Okay, this takes me a little bit of time to teach you. So if you look at page 108, you can see there's nothing really for us to learn here as far as principles. We know all the principles involved in this skill. So theoretically, there's not a whole lot other than skills specific for you to master. But remember, like everything else, we're still going to read the care plan. We're still going to do our opening. We're still going to decide if we need gloves. We're still going to do the closing. That doesn't change. We still have linen rules because we're going to be using a towel to cover them. So the towel can't touch your clothing. You can't snap it or shake it. You know, all those same rules are going to apply. But the skills specific steps for this take me a little bit of time to teach you. Now, you've been feeding yourself for years. You know how to feed people. That's not the issue here. The issue here is understanding some things that maybe you haven't thought about because they don't really apply when you're feeding yourselves, okay? So if you look at page 108, you can see that I have a video for this. You can see all the principles involved. You can see the short version at the top, and along the bottom, you see the test-specific information. Somebody with your level of experience should be able to feed somebody within 9 minutes or less. Now, for the test, our care plan is telling us to give the patient a snack. So let's talk about the test for a second. Let me go back. Who are we doing this on? Yeah, a real person. So one of you guys might be eating for the test. Yeah, unless you're the nervous type, that might be a problem. All right, so our care plan tells us to feed the resident a snack who is unable to feed him or herself. Resident is sitting in a chair in an inappropriate position for eating. Underline that. In an inappropriate position for eating. Now, you will see this on the testing care plan. You will not see this in a clinical setting. In a clinical setting, they're relying on you to look, you know, to see, is your patient in an appropriate position for eating? If not, you got to address it. So they're relying on your observation in a clinical setting. But for the test, you guys will be a patient. So your idea of slouching or slumping may be completely different from the person doing the skill. Like this. This is not an appropriate position for eating. Every 10-year-old kid in the world eats like this. Sitting up straight. So you may not consider this inappropriate, especially if you've got a 10-year-old kid in the house. Okay. So our care plan is specifying that no matter what your eyes are telling you, you have to address this. Good? Does that make sense? So a testing checkpoint for this skill is going to be ask our patient to sit up straight. Good? So that's why it's on the care plan for the test. It also tells us to document intake on a food and fluid intake form. You can see a sample of that food and fluid intake form there on the side of the second column. You can see a full version of it on page 186. I think 186. Try 186. No, 168. Ah, I was right. 168. Or 169, I think, is where the food and fluid one is. Yeah. So you guys have these documentation forms available to you. I've got a short version where they're all on one page over here on the clipboard for you to play with. Same form, just all on one page for you guys to play with. But you can print these off and make copies of them and use them when you're documenting. So you can kind of get used to how the documentation form is going to look for the state exam. If you look at that documentation form, you'll see that it has a checkbox format. So it's going to ask you whether you're feeding them a meal or a snack. What does our care plan say? Snack. So make sure you're checking the appropriate box there. We're going to get into the percentages here in just a minute. If you look at the supplies at the bottom of the page, you'll see that we need a towel or some other type of clothing protector. We need a hand wipe, the food tray, a pen, and a documentation form. The evaluator will give you the pen and documentation form at the beginning of the skill. We're going to talk about the rest of it in a minute. What makes feeding different is that it doesn't follow any of our normal rules. And this is why I usually save this toward the end of the program, because I want you to learn the rules. And then I'm going to tell you to break them. And let me explain why. So this doesn't follow our normal rules. We do not use a barrier on the table. We're not going to go get a barrier because our food tray is the barrier. We don't need a barrier. Make sense? Okay. We're not going to close the privacy curtain for this skill. It's the only skill that we don't close the privacy curtain for. And that's because eating is social. Think about all of the things that you do in life, all of the celebrations you have in life. They all revolve around food. Birthday parties, weddings, anniversaries, baby showers, graduations. They all revolve around food. Even funerals revolve around food. Eating is social. Does that make sense?
When you think about it, it is.
Yeah, eating is social. Now, you've probably been told don't talk with your mouth full. Well, we all know this. It's rude. However, if you guys go over to Cody's after class today, buy one, get one fajitas, by the way. You guys all go over to Cody's and you walked in and there's like 100 people in Cody's because buy one, get one fajitas is pretty popular, right? I don't get paid for that, by the way. That is not a paid product endorsement. But if you go in there and there's 100 people in there, if it were dead silent, how awkward would it feel? You expect a certain amount of commotion and conversation and noise in a restaurant. If you walk in and nobody is talking, everything is dead silent, how would that feel? Uncomfortable, eerie, weird, something is wrong here. So although you have been taught don't talk with your mouth full, it doesn't mean we don't talk during eating. You say something, I'm eating, I chew while you're talking, and then I respond and you chew. You don't realize that you do that, but that is what you do. Conversations occur. This is why dates usually happen in a restaurant. Conversations occur during feeding, but it goes beyond that. Because if you don't have anybody to have a conversation with, if you're eating alone, you're probably not just staring at a blank wall. You're watching TV, you're on your phone, you're listening to a podcast, you're watching a movie, you might be reading, but you are doing something social. You rely on socialization to stimulate your appetite. You guys understand that? So if we understand how important conversation is, that means that during the test, we're going to be required to have a conversation. It is the only skill where you are graded on having a conversation. It does not need to be real. You can make something up. Does not need to be real, but it does need to happen. Okay? Does that make sense? So you can say something like, they're showing a movie on the big screen in the activity room. Do you want to go? I think it's Casablanca. I've never seen Casablanca. Have you ever seen Casablanca? I'm going to have a conversation about it. I can make something up for the test. Not a problem. Oh my gosh, they're playing bingo today. And Martha says she's going to win. The jackpot's up to like $2.30. Can you believe that? It's the biggest jackpot they've had here. You think you're going to win? Oh, I can make up a whole conversation. No problem. Did you see those little kids that came in for the 4th of July? They were so cute. They were all dressed in the red, white, and blue. Did you see that? Oh, they were adorable. It's fine. Make something up for the test. But you need to have a conversation. You're graded on it. Now, in a clinical setting, we're not making stuff up. We actually want to have a real conversation with these people. So how do you do that? They're strangers. How do you start a conversation with a stranger? Well, if you're in their room, look around for clues because we display things that we are willing to talk about. I have a picture up there on my bookshelf of my husband and I on a cruise. If it's a picture on a bookshelf in public, that means I am more than willing to talk about cruising. My husband, a trip we took, whatever. I'll talk to you all day about cruising. I am a serial cruiser. I've got almost 30 cruises under my belt. Next one will be 30. Yep, I love cruising. We cruise from Tampa because it's quick. 4-day cruise, long weekend. I can get on really cheap if I do a last minute special. It's a lot of fun. So I cruise. I am willing to talk about that. So if you were feeding me and you looked around and saw that picture, that is a good conversation opener. We don't put things out that are our deepest, darkest secrets. If it's displayed, it means it's a conversation starter. So if there's a statue that you want to ask about, if there are drawings on the wall or paintings or whatever. But if I'm in a patient's room, particularly a female patient, I look for a photograph, and I'm looking for a very specific photograph. A lot of our older female patients have a photo, black and white photo, of them dressed to the night. Man, these women put us to shame, ladies. They knew how to pull themselves together. And they're usually standing next to a man in uniform, and they are, big grins, and, life is happy. If I see one of those pictures, I will always point at it and say, oh my gosh, what a beautiful couple. Did you know them? Were they movie stars? Did you know them? Who is in that picture? Them, her specifically, right? But I play dumb. Are those movie stars? Did you know them? Watch her sit up a little straighter and go, oh no, honey, that was me. Now, what did I do? What did I do with that one comment?
It made her feel good.
I made her feel good. What do you think that's going to do to her appetite?
She's gonna eat.
That's right. That's right. Did it cost me anything? And I have set the stage now for a good patient encounter. So that photograph just gave me a whole conversation opener. So where was that? What's his name? Does he have a brother? Right? And that's the response I get. I get a chuckle and a grin, right? Well, where were you when that was taken? Can you tell me a little bit about your story? People will talk about themselves. All they need is an opening. If you want to be known as the best conversationalist, learn to shut your mouth and open your ears. Now, there's a trick to this, though, because most people just listen to respond. Most people listen to respond. I don't want you to listen to respond. I want you to listen to understand. It's a totally different way of listening. So over the weekend, this is a homework assignment for you. I want you, when you're talking to somebody, to stop and think about what I just said. Am I listening to respond, or am I listening to understand? I want you to start to become aware of the difference. And once you become aware of the difference, then you can work on strengthening your listening to understand skills. Have you ever been in a conversation with somebody and they say something, like, oh, I don't feel good, or oh, I'm super tired, or whatever, and your response is, yeah, same. Okay. Or, yeah, I didn't sleep well last night either. Or what you're trying to form a connection. You're trying to bridge that gap. Does that help that patient at all, knowing that you also didn't sleep well last night? No. So what you did was you listened to respond. You did not listen to understand. Understanding means you're going to ask more questions. You're going to make the focus them, not you. You see that there's a difference there? Conversation with patients is important. This feeding patients is where you're going to get the most information from your patient. It's the one time that you have to slow down and listen to them. So this is where a lot of things come out. A lot of fears, a lot of anxiety, a lot of complaints. This is where things come out. And if you're just listening to respond, you're going to miss it all because you're making it about you. Remember observation and recording that we started with today? This is observation. This is where we employ that skill. Does that make sense? Okay. Do you see why this takes me a while to teach you? You also have to sit for this skill. It's the only skill that we are required to pull up a chair and sit. You can't stand over somebody and shovel food into their mouth because they will feel rushed. They'll feel dependent, and they generally feel like they're in imposition. So they won't eat very well. If you're standing over somebody trying to feed them, it's putting you at a different level. You're no longer eye to eye. And that affects the way the patient's going to eat. So you have to pull up a chair and sit. You don't have to sit for any other skill, but you do have to sit for feeding. So if you get feeding, there will be a chair there. They're seeing if you're going to use it. Now, I'm going to tell you a story about this. We had a patient many years ago in the nursing home who was losing weight. And I mean, when I say losing weight, she was under 100 pounds. She was losing weight. And she was not eating well. You know, the documentation forms, you know, she was only eating like 20%, or I'm sorry, 25%, 50%. And I'm starting to worry that maybe she has cancer or something is going wrong with her, or swallowing difficult. I'm always on the medical side, right? I'm trying to figure out what's wrong with her. And I actually walked by her room one day and I saw the CNA feeding her, and the CNA was facing the TV doing this, watching TV. Yeah, wasn't paying a bit of attention to the How do you think the patient felt?
Like she didn't matter or something like
That's it. Yeah. So why nobody cares? Why am I even here? So the patient is trying to commit suicide slowly because of the way she was being treated. Should we be doing that to patients? Especially if they're handing us $9,000 a month? They're paying not just for the physical care, but also the emotional care. Does that make sense? So I actually went in, got the CNA out because she really aggravated me. And I told her, go do something else. I'll talk to you. Because I never yell at you in public. God help you when I get you alone, though. So I sat down and I said, oh, Mary, I have had a day. Do you mind if I sit down for a second? Can you eat slow? I need some time here. And I started talking to her as I was feeding her and had a conversation. And after a couple bites, she goes, oh, no, honey, I know you've got a lot of things to do. Just go on. And I'm like, no, I need to sit. Come on, just a couple more bites. Keep me here a little while. She ate that whole plate.
Wow.
Now, why did she eat a whole plate for me and not for the other CNA?
You made her feel seen.
That's right. I had a conversation. I made her feel like she mattered. She was helping me, not the other way around. So sometimes you have to employ these techniques to get our patients to do things that benefit them. Does that make sense? Okay. There was another CNA. This one was really bad. The CNA kept putting down that the patient refused food. The patient could not feed himself. He was a full feed. Could not feed himself and was nonverbal. Couldn't talk. The CNA was putting the food tray on his table in front of him where he could see it and smell it, and then not feeding him and writing down that he refused food. That's criminal. That is criminal. That's exactly right. Yeah, we have rules that we can't do that with prisoners. That's part of the Geneva Convention. You have a lot of power as a CNA over people that are less able. And sometimes we wield that power for evil and not for good. If you notice that somebody is doing something that puts our patient at risk, see something, say something. because you may be the only thing standing between that patient and death. Not everybody out there deserves to be a CNA or a nurse or a doctor. Your job is to protect the patient. Good. I could spend weeks talking to you about all the news articles that have to do with caregivers taking advantage of patients. We had one about 6 years ago, a patient that gave birth in a nursing home. She was a young woman who was a drowning victim when she was 2, had serious brain damage. She was in a nursing home, and one of the nurses raped her repeatedly and got her pregnant.
Oh, I saw them in a documentary.
Yeah. Yeah. You cannot tell me that other people in the facility did not know what was happening.
They had to suspect something.
Absolutely. Yeah. So again, see something, say something. Don't cover for your coworkers. Your obligation is to the patient. If you don't take anything else out of this classroom, please make sure you remember that. You're the ones working with the patients every day. Good? Okay. So these are ways that feeding doesn't follow our rules. We don't use a barrier. We don't close the privacy curtain. We have to sit and have a conversation. Other things that we want to consider is eating rituals. Most people wash their hands before they eat. If you don't, you should. We talked about portals of entry, right? But most people, it's part of their eating ritual. They go wash their hands before they sit down to eat. Well, if we are feeding a patient, we want to keep up that ritual. We're going to give them a hand wipe to wipe their hands before we feed them. But even if we're feeding them, there's a possibility if food starts to fall on their face, slip out of their mouth, they may reach their hand up to wipe the food away or push it into their mouth or whatever. You don't want dirty hands up near their mouth. So this is a hygiene issue as well as a ritual issue. But giving them a hand wipe or helping them wash their hands up can help stimulate the appetite as well. Guys, this is what you need to understand about feeding, is this is the hardest skill to be a patient for. Now, we're going to go over Peri-Care in just a few minutes, and most of you guys are like, oh, no, that's got to be the hardest skill to be a patient for. Personal care below the belt, right? That's got to be the hardest skill to be a patient for. But in reality, this is. This affects you psychologically in a way that no other skill does, because eating is the very first skill you become independent at. You learn how to hold a bottle long before you sit, stand, crawl, or walk. You sit in a high chair and pick up Cheerios and diced peaches off a high chair tray and get them to your mouth before you even understand what hunger is. Eating is the first skill you become independent at. You feed yourself before you say words. Do you guys understand that? So when you lose the ability to feed yourself, it affects you psychologically in a way that no other skill can. It makes you feel very dependent. It makes you feel like you're an imposition, like you're worthless. This affects patients on a psychological level like no other skill. So if we feed into that, if we make the patient feel like they're worthless, they will give up. Failure to thrive happens all the time. So we need to be aware that how we approach this skill is super, super important. Does that make sense? Okay. This is actually the hardest skill to be a patient. Patients will absolutely, if they can feed themselves, they will. And we have all kinds of adaptive equipment now that they can use. If you have a patient with Parkinson's that shakes really bad, it's hard to get the spoon to your mouth because it shakes really bad. Well, we have self-leveling spoons that even though the hand is shaking, the food or the spoon stays, right? So if a patient is using adaptive equipment to eat, we need to make sure that adaptive equipment is available to keep their independence intact. A lot of CNAs will go, oh no, I'll just feed you, it's quicker. Should we be doing that?
No.
Understand there's a psychological cost to that. Okay. Good. Makes sense? So we're going to promote independence wherever possible. Sometimes this means, especially with our dementia patients, sometimes this means finger foods. You know, having a sandwich cut in quarters so that they can feed themselves. If they forgot how to use forks and spoons, finger foods work fine. A lot of times when we're feeding patients, we puree their food, or the kitchen does actually, purees their food, which means chopping it up into more like a paste so they don't have to chew it. That alters the texture just so they don't have to chew, but it doesn't alter the taste. So many years ago when I was a hospice nurse, I went into a nursing home to see one of my patients. Her name was Mary. Name has been changed. Her name was Mary, and she had had a stroke, was nonverbal, had right-sided paralysis, limited mobility on the left side, but she had cancer as well. And the cancer is why she was on hospice. But she was in the nursing home, and they were caring for her, and the CNA was feeding her. Now, she's in the dining room of the nursing home at a table with 3 other patients and a CNA who's feeding. And I walked in, it was lunchtime. I go down to the dining room and I said, hey, Mary, how are you doing today? And she didn't have dementia. She was very much with it, but remember, her communication skills are impaired. Well, she would look up kind of out of the corner of her eyes, kind of like this, turn away from me to let me know that she didn't like something, right? That was a kind of a facial expression communication. So she did that. And I said, oh, don't like lunch today? So I looked at the plate and it's this big gray glob of gook. I have no idea what it was. I'm just like gray. Oh, that doesn't look good. So I asked the CNA, I said, what is that? Or I said, what? No, sorry. I said, what's for lunch today? And the CNA said, Salisbury steak, mashed potatoes, and beets. I said, okay, but what is that? She said, Salisbury steak, mashed potatoes, and beets. All mixed together? And she said, yeah, it's pureed. They don't taste it. Oh, no. Would you eat Salisbury steak, mashed potatoes, and beets? Beets don't go with anything, guys. Would you eat that all mixed together? She says, oh, no, that's gross.
Why are you giving it?
Exhibit A. And she says, it's pureed. They don't taste it. No, they do taste it. I said, is anybody here eating well? She says, oh, now that you mention it, no. We can do better than that. Puree does not mean no taste. Does not mean bland. It just means that we chop stuff up so they don't have to chew it. So don't mix a lot of stuff. Sometimes it's not what we know that gets us into trouble. It's what we know that's not correct that gets us into trouble. So when food is pureed, keep them in their separate piles unless the patient wants the mix. Now, that brings me to my next topic. Everybody has different food preferences. How many of you guys don't like your foods to touch on the plate? Do I have anybody here that doesn't like their foods to touch? What's that?
My boyfriend doesn't.
Okay. So some people don't like their foods to touch. If you don't like your foods to touch and somebody's feeding you and mixing everything on the plate, you're not going to eat. Some of you like your corn and mashed potatoes mixed. Some of you are like, no, I do not want corn in my potatoes. Thank you. Some of you eat salad before a meal. Some of you eat salad with a meal. And some of you eat salad after a meal. That's actually a European trait, certain areas of Europe. So you can't assume that the way you eat is the way everybody else eats too. And this goes along with drinking as well. So for the test, we're going to offer a drink before and every 2 or 3 bites as we feed them. Now, the reason for this is some people drink before a meal. My aunt did that. She would drink an entire glass of water before she ate anything. And she had been a model previously, but she's felt that's how she kept thinner. And it doesn't work for me. I drink a glass of water, I still eat, but she would always drink an entire glass of water before she ate. Now, some people drink with a meal. That's me. My mouth dries out really quickly. That's why I drink a lot while I'm teaching. So I have to drink with a meal so that stuff goes down well. Now, my husband is just the opposite. He doesn't drink before or during, he drinks after, right? So everybody has different preferences. So we have to be careful not to impose our preferences on our patient. So this is why this conversation that we're having has a lot to do with the patient, not feeding. Good? Does that make sense? Okay. So for this skill, we want to make sure our patient is sitting upright. We're going to offer them a hand wipe. We're going to sit down and have a conversation. We're going to offer them a clothing protector too. Now, they don't have to use one, but we're going to offer it. We don't call it a bib because they're not a baby. We're going to call it a clothing protector. And we can use a towel. You can use a washcloth. You can use anything, just something to cover the clothes. Now, some of your patients will not want that clothing protector. My grandmother would have been one of them. Absolutely not. I am not a child. I know how to get food in my mouth. Thank you very much. Okay. Me, I need a clothing protector because I drop everything. I'm a messy eater. So your patient has the right to make that decision, that preference. So we're going to offer, would you like a clothing protector? For the test, they could say yes or no, doesn't matter. When we feed them, we're going to feed slowly, and the spoon should only be about half full. Don't overload your spoon to get it through quick. So your spoon should only be half full, and you want to give them time to chew and swallow. And this is where you're going to be talking to them. And then in between bites, they'll talk. Good? Make sense? All right. Let's go back to conversation for a second because I skipped something that I needed to tell you. So when it comes to conversation, you need to have some conversation starters. Sure, we can look in their environment and look for pictures or different things that they are willing to talk about, but sometimes we don't have anything, like especially if we're in the dining room. I mean, there's no visual clues. So what can we do? You have to have a couple of conversation starters. And it's okay to ask things like, what did you do for a living? Or what was your favorite hobby that you had? Or where did you grow up? Remember, people like to talk about themselves. All they need is an opening, right? But my favorite conversation starter is, what's the most exciting place you've ever been? I love that question because most people have gone to more than one place. So it takes them on a trip through their memories, which is always a good option for conversation. But sometimes your patients will surprise you. I had one lady I was doing wound care on. This is up in Citrus County. This is probably about 20 years ago. I was doing wound care on her. And it was a very extensive wound care. It took a long time to take the old bandages off, clean everything, and put the new ones on, about 45 minutes. So I pull up a chair. We're going to have a conversation because I'm going to be here a while. So I asked her, what's the most exciting place you've ever been? Now, she was in her 90s, living in assisted living facility, still very, very sharp as tack, but she had some mobility issues. And she says, oh, honey, I've never been anywhere. So she thinks the conversation is over. And I said, you've never been anywhere. This is Citrus County. You had to have gone somewhere like Ocala. She said, oh, no, I've never left the county. What?
Excuse me?
You're in your 90s. You've never left Citrus County, never once. And she says, well, that's not entirely true. I was born in Brooksville, but I don't remember it. Well, of course not. You were born. But you've never left the county? And she said, no. Now I'm settling in because this is living history. This is somebody who has been in Citrus County for almost 100 years. Like, how often do you get those opportunities? So I'm settling in. What changes have you seen? She was living in Inverness before the roads were paved. Think about that. Before there were any paved roads in the county. She remembers when the first auto dealership was put in. And she knew the family that got the first car in the county. She remembers the two families that were fighting, and the boy was supposed to marry the girl to solve the fight, and the girl ran off with another boy, and what a scandal that was. She remembers when the first McDonald's went in. This is living history. Sometimes your patients that think they have nothing to offer can have the most interesting conversations. I met a man that was knighted by the Queen of England. I met a man who was a engineer on the Apollo mission, the one that put the men on the moon. I've met pro athletes that made their living. I've met professional musicians. And you never would have known it if you hadn't have asked. Every patient has a story. Some are big stories. Some are little stories. But every patient has a story. And how horrible would it be to get to the end of your life and nobody wants to hear your story? It might make you wonder, well, what was it all for? So being there to listen to their stories is an important part of what we do. They just need an opening. Make sense? We're going to encourage the patient to eat. Now for the test, if you're the patient for this, let's say that you're the patient and you're going to feed her. I'm going to take you aside and I'm going to give you very specific information about being a patient for this. I'm going to tell you either slump or slouch when you sit down in the chair. Only take 4 bites, and no matter what they say, just say, I'm done, I'm finished, I'm full. And be cooperative. Like, eat like you eat. Don't drool, don't spit, don't do anything crazy, okay? So when you're feeding her, after 4 bites, and remember your spoon should only be half full, she's going to say, I'm done, I'm finished, thank you, whatever. Now, you have to encourage her to eat. So you're going to use at least 2 methods. I'm going to give you 3. You have to use at least 2. The first thing I'm going to say is, are you sure you don't want just 1 more bite? People do better with nice than nasty. And remember, your patient probably feels like they're in an imposition. So by encouraging them, are you sure you don't want just 1 more bite for me? Or come on, take another bite so I can sit for a minute. Is something like that to make it more that they're doing you a favor will usually get them to eat a little more. Patients that are being fed statistically do not eat well. So offer them or, encourage them to take another bite. If they say no, I will offer them something different. Now, we've all had days like this. We get something, we take a bite, we're like, nope, that's not it. Not what I was looking for. So maybe your patient is having that situation and they don't feel comfortable asking for an alternative. So if they only take 3 or 4 bites, I'm going to ask them, do you want something different from the kitchen? Maybe this isn't it. Would you like a sandwich or something? I'm going to offer something different. And the third thing I'm going to do is remind them that there's food available later if they get hungry. So it's all about improving their intake. You have to use at least 2 of those on the state exam. Are you sure you don't want just one more bite? Would you like something different? We have food available if you get hungry. You have to use at least 2. You don't have to use all 3. I usually do. Good? Okay. We're going to leave the area around the mouth clean and we're going to document. So at the beginning, we offer a hand wipe and a clothing protector. We're going to sit while we feed the patient. We're going to offer a drink before feeding and every 2 to 3 bites. We're going to feed slowly with the spoon only half full. We'll have a conversation when feeding. We're going to encourage the patient, and then we're going to leave everything clean and do our closing. Good? All right. So now we have to talk about the actual documentation portion of this skill. Hold on, I've got a comment over here. Okay, Vanessa says, I'm deaf, hard of hearing, and no ASL and know how to communicate with them. It's super sad. Yeah, and that's what I'm talking about with the disabilities. You may still be able to work. Have you had patients in your RN position that you dealt with that are deaf or hard of hearing? Yes, absolutely. And I actually took a sign language class when I was young, in my late teens, early 20s, to communicate with hard of hearing and deaf patients. So I don't remember as much as I used to because I'm not using it a lot, but I can have a basic conversation, yeah. Not required, but if you're working with a patient long-term and they do use sign language, it might be nice to pick up a few terms so that you can communicate effectively. All right, so let's talk about documentation here. This is the documentation form that you're going to be using on the state exam. And if you remember, your patient is only going to take 4 bites and you're only filling the spoon half full. For the test, what we're feeding you is either a single serve pudding or a single serve applesauce. Only 4 half full spoons. Guys, you got 9 minutes to do this skill. And we're only giving them 4 half full spoons. This is not going to take anywhere near 9 minutes to do on the state exam. Don't rush this. So we've gone over most of this. Details matter. We're going to offer a hand wipe, offer a clothing protector, offer a drink before feeding and every 2 to 3 bites. Let them lead. Feed slow, spoon only half full, and no childlike feeding techniques. No planes, trains, or automobiles, please. Now, I will tell you that in my career, I have had patients that I have played around with because humor does work. But we're not going to do that for the state exam. That's demeaning. If I'd done that with my grandmother, I would have been thrown out of the room. However, there are some patients that I can get, if I joke around with them a little bit, I can get them to eat a little more. You'll figure out who is who as you go through your career. But because we're only feeding 4 half spoonfuls, they're not eating a whole lot. So when we document, we have to document on what we call a quarter scale. So a quarter scale looks like this. 100%, they ate it all. 0%, they ate nothing. And then there's 3 steps in between. So 0%, they ate nothing. They refused. 25%, they picked at it. They ate a couple of bites. If we're only feeding 4 half spoonfuls for the test, it's going to be 25%. Good? 50%, they ate half, roughly. Right? We're not measuring anything. Half. 75, they ate most. but they didn't completely finish it. 100, they ate it all. Good. So this quarter scale is what we're going to be using for documentation. So if you look at this top plate is what we started with. We had a sandwich, broccoli, and Jell-O. Does not sound very good together, but a sandwich, broccoli, and Jell-O. So if we look at the first one there, how much of that meal did they eat?
25.
Yeah, they ate a couple bites. What about the second one there? Yeah, roughly half. Remember, we're not measuring. It's an estimation. What about the bottom on the left there? 75. What about that one? 100. Yeah, the broccoli stalk does not count. It's fine. Good. So we're going to estimate the amount of food that the patient ate. We're also going to estimate the amount of liquid that they drank using the same quarter scale for the test. So if they took a sip or two, 25%. If they drank half of the cup, 50%. If they drank most of the water, 75%. If they drained the cup, 100%. Okay. Now, I don't know how much your patient is going to drink during the test because they're nervous. Not only are they being an actor right now, but they're getting ready to test themselves. So they're probably pretty nervous. So nervous people tend to drink a little bit more, so they may drain that cup. Could be. And that's what we're going to do for the test. But in real life, we don't use the quarter scale for documenting liquid intake. We use actual numbers. When we're converting numbers, 1 ounce is worth 30 cc's. Cc's and mLs, same thing. Cc's and mLs, 2 words, same thing. But pre-packaged drinks will already have on the package how many ounces and usually how many cc's. So if you look at your water bottle there, look at the label under the name. It should tell you it's like 15.9 ounces or something like that. 16.9. Right beside that, in parentheses, it probably has mLs. 500 mLs. So your water bottle the same?
Yes.
Okay. So pre-packaged, my Dr. Pepper over there, might be the same. Let me look. Yep, mine is the same. So for those of you playing along at home, if you don't have a bottle next to you, I am not advertising for Dr. Pepper. All right, so if you look here, I don't know if you guys can see this. I don't know if it's going to show up. If you look here, it's 16.9 fluid ounces, but right next to it, it says 500 mLs. So when we're working with pre-packaged items, we just get the mLs right off the package. Easy. But we don't always have that option. Like if this, can I borrow this? If this is what your patient was drinking out of, and they drank the whole cup, well, we need to know what to document. So we would need to know how many ounces this cup actually holds. When you go into orientation, no matter where you work, part of your orientation is going to be discussing the cups that are used in that facility and how many ounces each of those cups holds. So water cups are 8 ounces. Coffee cups or water cups might be 6 ounces. Coffee cups might be 8 ounces or 10 ounces. The little juice containers, those are 4 ounces, but it actually says it on the container. Your little mini cartons of milk, those are 8 ounces, but it actually says it on the container. Make sense? Good. So if it's a prepackaged, we're going to use the container reading. If it's like a cup that doesn't say on there, it's not prepackaged, we need to know how many ounces it holds. And then we're going to do the conversion. So here we have an 8 ounce cup. Each ounce is worth 30 cc's. So in order to convert this 8-ounce cup of water into cc's, I've got to multiply 8 ounces by 30, and that's going to give me 240. This is a 6-ounce cup of coffee. I would multiply 6 by 30 and get 180. Good? Make sense? Okay, go to page 106 in your book. This is an activity. So those of you who are playing along at home, if you've got your book, page 106, you can do this activity as well. So if you look here, you can see what we started with. And I want you to identify what percentage each one of those plates, how much the patient ate. So go ahead and take just a minute or two. Remember, it's an estimation. How much did they eat? Not how much is left on the plate. How much did they eat? So if we look at the first one here, there's nothing left. So they ate 100%. That one's easy. The second one, well, there were 2 eggs. Now I've got 1. There were 3 slices of bacon. I got 1.5. There were 2 pieces of toast. I've got 1. There were 2 pieces of cantaloupe. I've got 1. So that's 50. Yeah, they ate half of everything. This one's a pretty good half because it's half of everything. Number 3, they ate most of it. Not all, but most. So what would we give them credit for? 75. And then number 4. Yeah, they just kind of picked at it. They ate a little bit of the bacon, a bite of toast, maybe a bite of cantaloupe, but that was it. Let's go up to the second column here. This is your starting plate. If you look at this, look at number 7. How much did this patient eat? 0. They refused. Do you guys see how that works? Okay. All right. So now down here is our conversion activity. So if we have 6 ounces of juice, we would multiply the 6 by 30 and get 180. 8 ounces of milk, our carton already tells us how many mLs, so we would use the carton. So that would be 240. And then 12 ounces of coffee, it's a pretty big coffee cup. 12 ounces of coffee, we multiply 12 by 30, and that gives us 360.
Oh,
Yep.
sorry.
1 extra 0 there. So 360. Now, at the end of the shift, you have to add up all the intake that the patient had during that shift. So we would add 180 plus 240 plus 360 to get our total intake for that shift. If you do the math there, you should come up with 780. So that would be our total intake for that shift. Good? 780? Okay. And I have a whole lesson on intake and output somewhere over there. Somewhere, 107 is a whole lesson on intake and output. All right, so let's go to page 132 for a second, and we're going to talk about medical abbreviations. On the state exam, there's very little medical terminology and medical abbreviations. That's not what the exam is about. That's not what you're going to be tested on, because it's not really much to do with CNAs. CNAs follow the care plan and report observations, right? It's not, there's nothing in there about perform high-level medical procedures. But you do need to have some familiarity with some of these terms because they're going to be used on the care plan. So on this page, I have the most common medical abbreviations that CNA should be aware of. The ones that are in gray, those are ones that may show up on the test. May. But the problem is that they're not going to ask you, what does PRN mean? It's not a definition type of question. They're going to work it into the question and see if you know what it means. The care plan tells you to turn the patient PRN. How often will you be turning the patient? Yep. But the answer choices would be once a shift, every 2 hours, as needed, or whenever the patient requests. Well, those all sound like good answers. If you didn't know, every 2 hours is how often we turn patients that are immobile. Every time they ask for it, yeah, that would be good, right? But that's not really what PRN means, is it? So can you see how if you don't know the term, it's going to be hard to answer the question? So anything in that's grayed out, you need to know. But this messes students up, so I want to spend just a minute on this. It's important that you know medical abbreviations are usually not abbreviated English. And that's why students really struggle with this. PRN is not abbreviated from any English words. It's abbreviated from Latin. Latin is the language of medicine. So you won't see, if you try to make it make sense, PRN, what does that mean in English? I don't know. It's not going to make sense because it's not English. The same thing if you come down here to NPO, and that's the one we need to learn for this lesson. NPO is abbreviated Latin, not abbreviated English. And what it means is nothing by mouth. So no food, no fluid. If your patient is NPO, we're not feeding them and we're not giving them anything to drink. Okay, make sense? Let me tell you a story about this, and I swear this is true. Doesn't sound like it. So, I work in the store. I own the store. And we have people from all over that come and shop here. And most of the nurses know that I teach CNA. And this one nurse that had been shopping with us for a long time, she comes in and she works down in Tampa at a teaching hospital down there. And she says, I have a story for you. I said, okay, I like stories. And she said, this is what happened. She works in the cath lab. We'll call her Kathy. She works in the cath lab. And she went up to get a patient. It's like 4:30, 5 o'clock in the morning. She goes up to get the first patient, bring him down to get him prepped for the cardiac cath. Doc's scrubbing in. So everything is in place. She goes up to get the patient, and the patient's sitting up in bed eating. And she's like, you're NPO. Why are you eating? And you're about to have a procedure. You can't be eating. And the patient says, yeah, I thought so. But the nurse brought this in and said I had to eat it before the procedure. So Kathy goes to try to find the nurse and asks, why is the patient eating? And the nurse says, I don't know. There's a student nurse with that patient. So she goes and finds the student nurse. And this is the conversation. I'm going to play both parts as it was relayed to me. Okay. So Kathy, to the student nurse, why is the patient eating? Student nurse, because the patient's NPO. Kathy, I know the patient's NPO. Why are they eating? Student, because they're NPO. I went and got the tray special. Kathy, what do you think NPO means? Student, nanas, pineapples, and oranges. So the patient did not get the heart cath they needed. The surgeon got to stand around with nothing to do until the next case was brought in, which made surgeons all kinds of happy, right? All because a student made up a meaning for an abbreviation they did not know. Now, Uncle Google is your friend, guys. If you don't know what NPO is, I guarantee you Uncle Google does, right? But at the very least, you should have enough academic integrity to say, I don't know what that means. Can somebody please explain it? Don't make stuff up And this one really just blew my mind because Nana's isn't even a word. Okay. Nana's a fruit tray. That's what she went and got, a fruit tray. Because in her brain, somehow she thought fruit, digestion. I don't know. I've been trying to put that together for years, right? We don't, but she didn't understand this, that abbreviations are not English. Make sense? Don't fake it till you make it. Not with real people. What if this patient had had a heart attack while they were waiting for the cardiac cath? It's a possibility. We don't want to play with this. Okay. So that brings me to understanding some of these medical abbreviations and their Latin origins. So we're going to go way back up here, and these are not grayed out, but I need to explain them to you. In Latin, Q, the word quaque, I think is how it's pronounced, means every. So QH would be every hour. Q2H is every 2 hours. Good? Makes sense? QHS, again Latin, means every hour of sleep or every bedtime. That's how they say bedtime. So if you don't understand that there's a Latin origin here, these just don't make any sense at all. And then we get to our BID and TID. Again, Latin. B stands for bi. Bi means two. Two wheels on a bicycle. Right? Bi means something completely different in today's world, but it's still two. Okay. So BID is 2 times in a day. Twice a day. TID, T stands for tri. How many wheels on a tricycle? How many angles on a triangle? Yeah, we actually use this. We just don't realize that we use it. T stands for tri. So TID would be 3 times a day. Good? Okay. So on the state exam, you may have a question that says you are assigned to walk a patient around the nurse's station, BID. What would be an appropriate intervention for this patient or something like that with 4 choices. If you don't know what that BID stands for, that whole question can throw you. It may have nothing to do with the answers, but just by throwing that in there, it may fluster you. So if you have an awareness of these, it helps you on the test, gives you a little more confidence. I've got a whole activity there on page 133 and 134 that helps you learn how these abbreviations are going to be used in a clinical setting. Good? Easy? So for this skill, we're going to document on the intake and output sheet. Again, food is intake, so make sure you put it in the right square there. And I've got a whole lesson on intake and output on page 107 that you can review on your own. All right, so let's go ahead and watch this video. I'm going to show you how to feed a patient. I don't have anything here to feed anybody, so I'll do the video.
Hello?
Hi, Mr. Jones. My name is Patty. I'm your CNA today. Would you like a snack?
Yes, please.
Okay, I'm going to go wash my hands, get my supplies, and I'll be right back. Can I ask you to sit up straight for me, please?
Okay.
Thank you. Okay, Mr. Jones, let me get you a hand wipe so that you can wipe your hands. Would you like to take that? Thank you very much. Let me
Thank you.
dispose of this. Okay, can I offer you a clothing protector?
Yes, please.
I'll just place this on your chest. Okay, it looks like we have pudding. How does that sound?
Great.
Very good. Can I offer you a drink before we get started?
Please. Thank you.
You're welcome. Okay, are you ready?
Yes.
There you go. Do you have any plans for this afternoon?
No, I do not.
They're showing a movie on the big screen in the activity room. Would you like me to get more information on that for you?
Yes, please.
Okay. How does the pudding taste?
Delicious.
Very good. Ready for another?
Yes, please.
Okay. Can I offer you a drink? Would you like something to drink?
Yes, please.
All right. Ready for another bite?
Yes, please.
Ready for another bite?
I'm actually full.
Are you sure you wouldn't like just one more bite?
I'm okay, thank you.
Can I get you something else from the kitchen?
No, thank you.
Okay. Let me know if you get hungry later, and we'll get something to eat. We do have food available on the unit.
Thank you.
Going to take the napkin. There we go. I'll remove this clothing protector from you, and we're going to put this in dirty linen. I'm going to go take care of your tray. I'll be right back.
Okay, thank you.
Okay, I'm going to place the tray back on your table. Is there anything else I can get for you? A magazine, perhaps?
No, thank you.
Your call light is within reach. Please let me know if you should need anything. I'm going to go wash my hands and document.
Okay, thank you.
After washing my hands, I'm going to document the amount of food that this patient ate. Using my documentation form. I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right. Any questions on feeding?
Leave the tray there?
Yep, you leave the tray there. In a clinical setting, we would probably take the tray back to either the food cart, because they bring all the trays up on a cart, or put it in our soiled utility room, or whatever our policy and procedure is for that particular setting. But for the test, we just leave it on the table. You don't even have to clean it, because that's dietary's job. Okay.
You take the towel off the rack to offer it, and they said they don't want it. Are you okay to put it back on the rack and get yourself clean?
No, yeah, put it in soiled utility. Anything that we take out of clean, we would put in soiled. And in reality, I'm going to redo these videos very shortly. In reality, I would probably ask before I got the clothing protector, because it's right there. All right. So now we're moving on to Peri-Care, the dreaded Peri-Care. All right. Nothing new to learn on this. We know all the principles. But man, there are a lot of principles involved here. If you look on page 152, we're going to do skill rules, opening, glove rules, barrier, privacy blanket, linen rules, scoot and roll, washing rules, basin, cleaning, and the closing. So the only thing that does not apply to this is shoe rules. Everything else is in place. So this is one of those skills that has a lot of steps to it. It's a washing skill. So just like partial bed bath was a washing skill, this is going to be very similar, but we're washing below the waist this time. Remember, partial bed bath was face to waist. Now we're going to go below the waist. For the test, they break this up into two totally separate skills. And that's because they want to be home in their pool drinking their Mai Tai, not watching you wash a whole body. So these are two separate skills. If you remember partial bed bath, they gave us 19 minutes to do that one. You guys remember that? Peri-Care, we've got 17 minutes. So it's still a long skill. Good? Questions? All right. Let's get into it. I do have a video for this. You can watch. You guys know where to find the videos? Okay. On my main website, warriorcna.com, under skills videos. That's the easiest way to find the videos to review them, but they're all in that online course that you guys have access to. So remember that course, and that course has sequencing activities. So it'll show you all the steps. You got to put them in the right order. And that's a really big help, because I know when you guys were practicing making an occupied bed on Monday, it seemed like a whole lot of steps and you're not sure which comes first, which comes next. Those sequencing activities are designed to give you that knowledge before you get up and start practicing. So it can really help improve your confidence before you practice, okay? So if you're not doing those online modules, you probably should, at least before you go test, because they're going to give you a layer of understanding that you're not quite getting here, because it makes you do something. Here, you're listening and you're getting information, but the online course is going to have you apply it, which is one step further in the learning process, okay? All right, so our care plan at the top of the page, 153, tells us the female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the hospital gown and bedding is dry. That's a miracle. Does not ever happen that way in real life. When you have a patient who is incontinent, their gown will be wet too. But we're going to take the gift that the test gives us because it's a nice thing that they're doing for us. Let's go back here. If you look on page 152 at the bottom of the page, you'll see this is going to be done on a mannequin. That mannequin will be lying in bed. The mannequin is not really going to be wet. The pads are not really going to be wet. This is our care plan scenario. We're going to have to use a little bit of imagination for this particular skill. Okay, good. All right, so supplies are at the bottom here, and I want to point something out on the supplies. We've got a barrier, and then we've got two under pads here. So it's all the same thing, right? They're all chucks, but we have one that goes on the table to hold all of our supplies, and then we need two when we do this particular skill. So we're going to talk about why we need two under pads for this skill, why that happens. I don't want you to leave two pads under the patient. We don't double brief. We don't double pad there. If your patient is wetting that much, you need to change them more often. Good? Not double up on the pads. All right, so let's get into how this works. 5th grade review of the urinary system. Again, 5th grade, oversimplified. This is way more complex than I'm about to make it out to be, but we're just going to go through an overview. You have 2 kidneys in your body. Those kidneys, its whole job is to filter your blood and pull out the bad stuff. It also helps regulate fluid balance in your body. Because our heart is pumping nonstop and all of that blood has to stop at the kidneys before it moves on, your kidneys work 24 hours a day. They don't take coffee breaks. There's no downtime. Your kidneys don't sleep when you do. Your kidneys work 24 hours a day, filtering your blood. As the kidneys filter your blood and pull out the trash, the bad stuff, and the excess fluid, it creates urine. As that urine is created, it drips down tubes called ureters and collects in your bladder. This happens 24 hours a day. Drip, 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 drip. Now, as those drips go into the bladder, there's a little valve at the bottom of the bladder that's going to hold that bladder closed, like a Ziploc bag. So that means that the urine is going to accumulate inside the bladder until it gets full enough. When the urine hits the top of the bladder, a little bell rings in the brain, says, hey, we're full. Go find us a bathroom. And your brain starts looking for a bathroom. You go to the bathroom, that valve opens, the urine goes out. When you're done going to the bathroom, the valve closes again. And now we've set up shop for the next couple of hours. Good? Everybody understand how that works? That's a normally functioning urinary system. How often do the kidneys work? Okay, so they're always producing urine, drip, drip, drip. That's going to be important in just a second. When we have incontinence, the system is still working. The kidneys are still filtering blood, producing urine 24 hours a day. That urine is still drip, drip, dripping down the ureters into the bladder. The part that's not working is the valve. That is the only part that is broken when your patient is incontinent. It's important that you understand that. It's the valve that isn't working. So, how often do those kidneys produce urine? Drip, drip, drip. That valve isn't holding those drips in. So, your patient who's incontinent is going to be wet all the time. If you've got a patient who is dry, 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 really, really wet, you do not have an incontinent patient. That valve works. You have incompetent staff members that aren't taking the patient to the bathroom. And this happens way more often than you would think. It is way easier for CNAs to say, hey, I'm just going to put a diaper on you. Just go. Just go whenever you need to. I'll clean you up later. Talk about a dignity hit. Would you wet yourself for somebody else's convenience? And yet it happens all the time. It is so common that the overseeing agency, what we call the Joint Commission, knows this is such a problem that if a patient comes into a facility continent, but while they're in the facility becomes incontinent, that facility is fined $10,000 per occurrence.
That's what they get.
Because CNAs can be lazy. Don't make your patient pee themselves for your convenience. Does that make sense? This is why I say don't double brief, because that's what a lot of CNAs do to buy themselves more time. That's horrible. It's horrible. We shouldn't be doing that. So let's go back to this valve for a second. When we're incontinent, this valve is the only thing that's not working. Well, the valve is a muscle. If we start exercising a muscle, what happens to the muscle? It gets stronger. So when we have a patient who's incontinent, a lot of times we're going to put them on a bowel and bladder retraining program. And that means I'm going to take the patient to the bathroom every 2 hours around the clock. I'm waking them up at 2 a.m. Come on, Mary, let's go to the bathroom. I'm waking them up at 4 a.m. Come on, Martha, let's go to the bathroom. If you do that, that's making that muscle move. And when we do that consistently, we can retrain that muscle to develop more control and to restore our patient's dignity and independence. How wonderful is that? Takes a little more work on our part, but it's worth it in the end. There's a lot of problems with incontinence, and that's what we're going to cover now. Adults are not like babies. These two are not the same. Babies, you put a diaper on them, put them in a crib, leave them there for 8-10 hours, wake them up, and they actually still have skin on their tushes. Yay. And that's because their urine is still alkaline mild. Adults, when an adult is exposed to urine, that urine is very acidic. And that acid eats into the skin, can cause rashes and sores and infections and all kinds of really bad things. So when we have a patient who is incontinent and that urine is on the pad, that urine is going to eat into the skin. We've got to change this person every 2 hours around the clock and clean them up so that that acidic urine doesn't have a long time on the skin. Remember, our incontinent patients are wet all the time. So as soon as you get them changed, they're going to start wetting again. And that's okay. We bought them a couple of hours. Does that make sense? Everybody got it? All right. So remember that adult urine and baby urine is not the same. And this is because our acidity level depends on what we eat. What we eat is normally very acidic. We like acidic foods and fluids. It's just our preference. And we need a certain amount of acid for all of our body processes. So whatever we don't use, we're going to excrete. Well, babies, they don't eat a lot of acid. They eat very mild things, formula, breast milk, pureed plums. I mean, very, very mild stuff. So their urine, mild, doesn't affect the skin. Adult urine, acidic, can affect the skin. Good? Let's talk about adult briefs. We don't call them diapers. They're not children. We call them adult briefs. We can also call them depends. We use these when the patient's out of bed because it's a dignity issue. Nobody wants to wet themselves in public. So this is a dignity issue. But that adult brief is going to hold that urine right up next to the skin. It's also going to trap heat, which makes it warm. It blocks light, which makes it dark. The incontinence makes it moist. What grows in warm, dark, moist? Pathogens. So when you have a patient out of bed and they have an adult brief, we have to clean them every 2 hours and change that brief. If they're truly incontinent, it will be wet. If you've got a brief on somebody that is not incontinent, so how do I know that? You check the patient every 2 hours. You come back and you say, oh, they're dry. Yeah, if you've got a dry incontinence brief, your patient is not incontinent. Why do you have an incontinent brief on them? That sounds like convenience to me. Or you lied and never checked. Either way, there's a problem. Right? You guys starting to see? Nurses have ways of knowing when you're doing your job. And we have to. Because it's our license on the line. Does that make sense? So if I asked you, did you check and see if they're wet? And if you come back to me and say they're dry, I'm going to have to watch you a little bit closer. Good? Okay. Yep, you'll learn. So we don't call them diapers. They have to be changed every 2 hours, and it increases the risk of infections in our patients. So when they're in bed, a brief is not the best answer. Some patients will want briefs on. That's fine. The care plan will tell you what to do. But if I've got a patient who is in bed and incontinent, I'm going to suggest that they be open to air when they're in bed. That allows the urine, no adult brief, just a pad. That allows urine to spread out on the pad, not against their skin. It allows light and air to circulate, so it reduces the amount of infections that we get. And that's how this skill is set up. Your patient, a mannequin, in bed, on a pad, and the pad is wet. It's not actually wet, but our scenario says it is. Okay? So now let's think about that pad for a second. Lesson last week, we learned that room temperature always wins. You guys remember that? Okay. So urine, our body temperature is 98.6 degrees. Urine is made right here in our furnace area. So urine, when it comes out, is somewhere around 100, 101 degrees. Just a little bit warmer than our body. Okay? So when urine comes out, it's about 100, 101 degrees. Everybody good with that so far? That urine is going to spread out on that pad and hit room temperature. What is room temperature going to do to the temperature of that urine? It's going to make it cold. So room temperature, let's just say it's 75. Anybody have a swimming pool? When you get into 75, you ever go to Weeki Wachee, Buccaneer Bay? Yeah. That water's 72. Okay. All right. What do we know about that water when we get in it? It's cold. Swimming pool at 75 degrees feels cold. So between 72 and 75, we perceive it as cold when it's liquid. Yeah. Your patient is laying on 72 to 75 degree liquid. What does that pad feel like? Cold, wet, probably a little slimy. If you are laying on that pad, what's first thing you would want done?
Change the pad.
Change the pad. Now we got a wet butt going on a clean pad. We still have to clean them, but we need them comfortable. Change the pad. This is why we need 2 chucks. change the pad, clean the patient front and back, and now we got a clean butt. We're going to change the pad again to put them on a clean pad. Good? You guys understand now why we need 2 chucks? Cold, wet, and slimy. Pretty icky. Washing rules apply. We know all these. Basins are no soap zones. We're going to use a paper towel to turn the faucet on. We use warm water, not hot, not cold, and we're going to ask our patient to check it as well. We're going to change the water if it gets cold or soapy every time, and we're going to use the leaves method. We'll talk about that in just a second. We're going to wash, rinse, and dry. And when we use the leaves method, we're going to use all 5 leaves. We're going to make sure our surface remains dry, so we'll wring that washcloth out really well so it's not drippy, and we're not using lotion for this skill. So let's take a look at the care plan one more time. It tells us the female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the hospital gown and bedding is dry. So, of course, we're going to start with our opening. Knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to do Peri-Care. Put it in any words you want. Nobody is grading you on your terminology. If you don't think the patient knows what Peri-Care is, you can say, I'm here to do personal care. I'm here to clean you up down below. Put it in terms that you think your patient is going to understand, but keep it professional. I wouldn't walk in and say, hey, I'm going to clean up your hoo-ha, right? We're going to keep it professional. But I can pretty much guarantee you that your patients know what Peri-Care means because CNAs do normal. You guys remember that? CNAs do normal. If this is the first time the patient's ever had Peri-Care, is that normal for the patient? Who does not normal? The nurse. And when the nurse goes in, they're going to explain what Peri-Care is. See how this whole thing works? So you can say, hey, Ms. Jones, I'm here to do Peri-Care. Your patient will probably understand exactly what that means. In fact, Peri-Care has to be done every 2 hours around the clock. So the patient probably knows way more about Peri-Care than you do. Okay, good? Makes sense? So when you're doing your opening, you can say, I'm here to perform Peri-Care. If you want to put it in normal English, you can if you'd like. Remember I said during the test, you can even go back and read that care plan. So you can read it right off the care plan. I'm here to perform Peri-Care to an incontinent female patient. I like to put it in more conversational terms. We're going to use a barrier. We'll get it first and then get the rest of our supplies. We're going to get water for bathing. We'll check it. The patient checks it. We'll put a privacy blanket on. We're going to put some gloves on. First thing our gloves should touch is the patient. And then we're going to change that chucks out. So clean rolls toward me. Dirty rolls away. It works here too. So we're going to take the dirty. This is just like changing a bottom sheet. It's just a lot smaller. So we'll roll the dirty one toward the patient, tuck it under them. Roll the clean one toward us and put it in place. Have the patient turn on their back, go to the other side of the bed, and repeat the process. Take the old one off and smooth the new one out, just like we did with the sheets. We're going to put a privacy blanket on the patient and pull the sheet down. Now, we want to do this before we put our gloves, or I'm sorry. Yeah, this is in the wrong order, sorry. We want to do this before we put our gloves on. Because remember, once you put that chucks under the patient, can you move your cup for me? Yeah. Once you put that chucks under the patient, you now have butt juice on your gloves. We don't want to touch that sheet with butt juice gloves. So let me explain something to you, the way this works. All right, so I'm here ready to do Peri-Care. I've got all my supplies. I've washed my hands. I've done all that. I'm going to put the privacy blanket on the patient. We're going to do this the same way we do every other privacy blanket. We're going to unfold it, lay it over the patient, and then pull it down. Patient can hold it in place if they can, that's fine. I need to pull the sheet down to about their knees. Doesn't need to go any lower because I'm not going any lower. But now I've got my gloves on and I'm ready to start the skill itself, the Peri-Care part. I need to roll her blanket up so that she's exposed so I can clean her. But I want to limit exposure. So when I do this, instead of, this is going to be uncomfortable for everybody, so just bear with me because I need to show you something. Instead of just exposing her, I'm going to take the blanket that's on top, this blanket, and I'm going to get the gown in the blanket, just like this. So underneath this blanket is the gown. And I'm going to roll the blanket and the gown together up to about there. And then I'm going to put a towel on her lower legs. And that's just going to restrict what's exposed to just this one area I'm working on. Everybody got it? Now, at the end of the skill, when I'm ready to turn the patient over to clean her backside, I'm going to unroll this blanket. And when I do that, see what it did to the gown? I don't have to touch that gown with my soiled gloves because think about where my gloves have just been. Now, that is professional. It gives a way different feeling than if I did this. Nobody is comfortable with this, especially the patient. Do you see the difference? So when you're performing Peri-Care, it really is important that we try to keep this somewhat clinical. Remember, we're in the most personal area of our patient. So by rolling the gown inside the blanket and stopping just above the peri area and covering the legs with a towel, this will make our patient feel much more secure. Good? Okay. All right, so we're going to cover the thighs with the towel to minimize the exposure as much as possible. Then we'll wring our washcloth out. We're going to apply soap to 5 leaves, and we're going to clean in this manner. So let me show you. Okay, so I have my washcloth. Remember, it's just a plain square washcloth folded in half and then in half again. I'm going to hold it as a diamond, tucking the 2 side corners in with the free leaves on the top. Good. Now, I am right-handed. I'm going to show you with my left just so that you guys can see, okay? You would use your dominant hand. So I'm going to hold her peri area open just a little bit by taking my fingers and kind of spreading her open and retracting just a little bit. Not a lot, just a little bit to hold her open. And then I'm going to wipe top to bottom, move away, and fold over. This is a one-way trip. If you hold open and go top to bottom and then back up, what you've done is taken bacteria from the rectal area and brought it to the urethra. That's important, especially with females, because our urethra is only about as long as your pinky. Bacteria, this is a day trip. No issues. You bring bacteria up to the urethra, it will get into the bladder. Now, the bladder is nirvana. It's warm, it's dark, it's moist, but it also has an open bar and an all-you-can-eat buffet. There's proteins and enzymes in the urine that makes it possible for those bacteria to multiply. Bacteria don't need little boy bacteria and little girl bacteria to make baby bacteria. It doesn't work like that. All bacteria need are the right conditions, and they zip themselves in half and make 2. Carbon copies. No gestation period, no 9 months, no hard labor. It's just, oh, cool. Enzymes, proteins, gobble, gobble, zip 2. And it happens that quick. So when bacteria invade the bladder in numbers, that infection can become overwhelming very, very quickly. Make sense? So we have white blood cells that hang out in our urethra. So if a bacteria should happen to stumble in here or there, the white blood cells will usually take care of it. But when we bring bacteria up by the busloads, those white blood cells can't really do their job effectively. And that's when infections occur. So when you're doing this, you're going to hold the patient open, top to bottom, move away, fold that down. That traps the contamination underneath. Then I'm going to go on the outside, top to bottom, fold that down. The other outside, top to bottom, fold that down. This one is going to clean this area here, but in the crease between your groin and your leg, that crease. So top to bottom, fold that over, top to bottom. This gets put away. Whatever we wash, the exact same way. So a new washcloth, no soap, wring it out. And we're going to hold open, down the middle, fold over, down one side, fold over, down the other side, fold over, skin fold over, skin fold. Set that aside. That's going to be shown to you on the next slide. So we never move back up with a washcloth during cleaning. It's only top to bottom, one direction only. Whatever we wash, we rinse the exact same way, and then we dry top to bottom. Good? All right. Then we're going to unroll that blanket to cover them, and that pulls that gown down. After we have them covered, don't leave them exposed. Remember, exposure should be minimum amount of time. So we're going to cover them back up. We'll have them scoot and roll away from us so we can then wash the backside. So leaves method, holding in my hand. I'm going to go from the rectal opening up the center crease, fold that over. One cheek, fold that over. The other cheek, fold that over. And once more up the center crease, because that's where all the urine is going to run, like a riverbed. Set that aside on my barrier. I'll get another washcloth, wring it out, and now I'm going to rinse. Same way I washed. Up the center crease, fold it over, one cheek, fold it over, the other cheek, fold it over, and once more up the crease. Set it on the barrier. Whatever we rinse, we dry. So I'm going to take the towel and dry all of those areas. Okay, so whatever we wash, we rinse, and then we dry bottom to top. Now we've got a clean butt, so we're going to change that pad again. So clean rolls toward me, dirty rolls away. Do you guys see how the principles that we've learned so far are just going to be used over and over and over again? You'll see that again on Monday as well. Monday wraps up our skills, by the way. We're almost done. And then we'll put the patient back in the center of the bed. Remember that we need our gloves on to put all of our washcloths and towels away. Right? Can we touch that sheet that's going to go up next to their face with those gloves? So we're going to leave our patient just like that. We'll be right back. And we're going to go dispose of all of our supplies, clean our basin and store it. And then we can take our gloves off, remove the sheet and pull the blanket up, or remove the blanket and pull the sheet up, and then do our closing. Good? All right, let me show you the video for this one. Oh, thank you, Marie. That's very sweet. Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to do Peri-Care. Is that okay? Okay, let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'm going to start out with a barrier. This gives me a clean place to place my clean supplies. So I'll place the barrier on the overbed table. And now I'll start gathering my supplies. I'm going to need 2 chucks, 4 washcloths, a privacy blanket, a towel. I'll place these items on the overbed table. I'll need a basin and soap. And I'm going to need a set of gloves. Okay, Miss Jones, let me go fill the basin. I'll use a paper towel to turn the water on. I'll make sure it's warm, not hot, not cold, just warm. Miss Jones, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place my washcloths in the water. Okay, Miss Jones, I'm going to place this privacy blanket over you. This is going to help keep you warm and protect your privacy while we do this skill. I'm going to spread the blanket out, being careful not to shake it or snap it. And then I'm going to pull your sheet down to about your knees. Now I'll get my chucks ready for use. I'm going to unfold the chucks, hold it up lengthwise, and roll it toward me. And I'll repeat that with the second one. Clean rolls toward me, dirty rolls away. Now I'll get my gloves on. Okay, Miss Jones, in just a moment, I'm going to ask you to scoot toward me, and we're going to roll you onto your left side so I can change the chucks that's under you. I'll place one of the chucks on the bed. Miss Jones, can you scoot toward me, please? Thank you. And roll up on your left side. 1, 2, 3. I'm going to roll the dirty chucks toward the patient. Tuck it under her hip. Unroll the clean one and tuck it under the soiled. Miss Jones, can you roll back onto your back, please? Thank you. And scoot to the middle of the bed. Okay, I'll come around to the other side of the bed now. Miss Jones, can you scoot toward me, please? And roll up on your right side. 1, 2, 3. We'll remove the soiled chucks from the bed and unroll the clean one. This is going to be thrown away. Okay, Miss Jones, we're going to start cleaning now. I'm going to roll your blanket up to about your waist. This is going to expose you. Please let me know if you're uncomfortable in any way. So I'll roll the blanket up, and on the way I'm going to try to get that gown rolled inside the blanket so that exposes only the peri area. I'll cover her upper legs with a towel, and then get my first washcloth. I'm going to wring this out and soak 5 corners. 1, 2, 3, 4, 5. Okay, Miss Jones, I'm going to clean now. I'll use the heel of my hand at the top of her peri area and my index and middle finger to spread her slightly open so I can clean down the inside middle, top to bottom, and then we'll fold that leaf over. We're going to clean the outside labia, top to bottom, down one side, and fold that over. The third leaf will clean the other side of the labia, top to bottom, fold that leaf over. The fourth leaf is going to clean this area between the leg and the groin, this skin fold, top to bottom. We're going to fold that over, And we'll repeat it on this side, top to bottom. Now we'll place the washcloth back on the barrier. The second washcloth, we're going to wring out. And we're going to rinse all of those areas the same way we washed. So we're going to hold her slightly open to clean down the middle, top to bottom. Fold that over. We're going to rinse down one side of the labia, top to bottom. Fold that over. Rinse the other side of the labia, top to bottom. Fold that over. We're going to rinse the skin fold down one side, top to bottom. Fold that over. And the other skin fold, top to bottom. We'll set that aside. Now we're going to dry all of those areas using short, soft strokes or a gentle pat. I'm going to unroll the blanket, which will place her gown back over her legs. Okay, Mrs. Jones, I'm going to scoot you toward me now, and we're going to roll you onto your left side so I can clean your back side. Go ahead and scoot toward me, and we're going to roll you over onto your left side. 1, 2, 3. The evaluator will hold the mannequin in place for you to complete your cleaning of the patient's backside. Okay, I'm going to take the fourth washcloth, wring it out really well, and we're going to soak 4 corners. 1, 2, 3, 4. I'm going to start at the anal opening and go up the center crease, right up the middle, and we'll fold that leaf over. The second leaf will clean one buttocks. We're going to fold that over. The third leaf will clean the other side of the buttocks. We'll fold that leaf over. And the fourth leaf will clean from the anal opening up the center crease one last time. We're going to set that aside. Whatever we wash, we rinse. So I'll wring that out. And I'm going to rinse the same way we washed. So from the anal opening up the center crease, fold that over. One buttocks, fold that over. The other side of the buttocks, fold that over. And once more up the center crease. And then we'll dry all of those areas. Okay, Ms. Jones, I'm going to change that pad out from under you so you're on a nice clean pad. We'll roll the soiled chucks toward the patient and tuck it under her hip. Unroll the clean chucks and tuck it under the soiled. Ms. Jones, come on back, please. And scoot to the middle. Thank you. Okay, Ms. Jones, go ahead and scoot toward me. And roll up on your right side. 1, 2, 3. Thank you. We'll remove the soiled chucks from the bed and unroll the clean. Okay. Go ahead and scoot back to the middle, please. This is going to be thrown away. Okay, Ms. Jones, I need to put all of my soiled items away and clean my basin. I'll be back in just a moment to get you situated. These items will go in dirty linen. And the basin is going to be cleaned the same way we clean everything else. We'll dump the water into the sink, rinse the basin, pick it up with a paper towel and dry the inside. We'll discard that paper towel. We'll dry the outside and discard that paper towel. And then we'll get the soap. I'll use the paper towel to open the drawer and store the basin back inside. These paper towels will now be thrown away. The barrier is going to be disposed of. And now I can remove my gloves. Okay, Ms. Jones, I'm now going to gather the privacy blanket up and pull your sheet back up. So I'll collect the privacy blanket by lifting from the bottom or underside of the blanket. I'm going to pull the sheet up and ball the blanket up into a ball. That way no trailing edges will contaminate other surfaces. Okay, Ms. Jones, let me go put this in dirty linen. Are you comfortable? Is there anything else I can get for you while I'm here, like a magazine? Okay, here's your call light. If you should need anything at all, please let me know. I'm going to go open your curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and then let the evaluator know my skill is done. Okay. All right. So that is all of the instruction for today. I've handed out your review sheets. Those of you that are attending virtually, please remember that you do have these review sheets available to you on the live stream page, flcnatraining.com. You can download these same review sheets that are being used in the classroom and fill them out. They do make a great review packet for right before the test. You have 2 chapters of homework to do over the weekend, chapters 8 and 9. 9 is on rehabilitation. So we talked a little bit about adaptive equipment in here today. So 9 is going to go over a little bit more of that. In chapter 9, I believe they're going to go over different patient positions. You do need to know those too. Fowler's, Sims, lateral, prone, supine. There's only 5 you need to know, but you will need to learn those. Now, chapter 8, though, I want to talk to you about really briefly. In chapter 8, it's all about nutrition. Now, nutrition is a super deep subject. This is just going to barely scrape the surface. The thing that I want you to know is that different diets are used for different purposes. We really are what we eat. And when patients have different conditions, certain things are going to be encouraged or restricted. So we have to understand that and abide by it. So if you're passing trays, you want to make sure you're giving the right patient the right tray because of these different diets. Does that make sense? So pay attention to chapter 8. It's a short chapter, but it's pretty meaty. No pun intended. So budget your time accordingly. Please remember that we do have CPR on Monday. It'll be at 2 o'clock. So we'll have class until 1, and then you'll have a break, or you can practice or whatever, and then we'll start the CPR at 2. You don't have to pre-register. Just show up on Monday, but it'll be your last chance to get it at the $45. After Monday, for you guys, it goes up to $55, which is what I charge the community. Okay? And then there's your review sheet. So any questions on what we went over today? No? Everybody comfortable? We only have 4 skills left to go. That's it. We have bedpan, caring for a catheter, which is Peri-Care with an extra step, and emptying the drainage bag, which is a 5-minute skill. So not a whole lot to teach you. We'll also go over the very last range of motion that we did not get to, but that takes like 5 minutes because you already know how to do range of motion. I just have to show you on that body part.
If we realize like halfway through the skill that we forgot a supply, do we just tell them that we're simulating hand washing and grabbing the supply?
Right. Yeah, just address that hand washing component. You've got to verbally say, I would wash my hands. I'm going to go get my supply. That way they know that you understand infection control processes, but they won't make you physically go wash your hands.
Okay.
Yeah. Good question. Very good question. Remember, you're not graded on supplies. No checkpoint that says you got the right amount of supplies. You're graded on what you do with the supplies. So if you don't have the right supplies, you're going to skip a step. Good. Any other questions? No? All right. The rest of the class is practice for you, or you're free to go. Have a great weekend. I will see you on Monday. For those of you joining us virtually, we'll see you guys Monday. Remember the game show on Tuesday, too. Game show's coming up on Tuesday. Till next time, guys, happy caregiving. Oh, Tamika. I take my exam on Monday. Have a great rest of the week and weekend. Oh, Tamika, we're going to send you lots and lots of good vibes. You're going to do fantastic. If you have not yet, go download my ebook and read it over the weekend. It's for your CNA/ebook. I'll put it in the comments. Make sure you take a look at that before you test. Okay, good luck. Bye, guys.